Good afternoon, everyone. I'm Linda Tintawi, the CEO of the Lustgarten Foundation, and welcome. This is our first Pancreatic Cancer Research Symposium as we celebrate our 25th anniversary. Lustgarten-funded science has been a driving force in every major development in pancreatic cancer research since our founding in 1998. As the world's largest private provider of pancreatic cancer research, we aim to advance breakthroughs in the understanding of the initiation and progression of pancreatic cancer to improve the diagnosis and treatment of the disease and provide more hope for the future. We fund the most high-risk, high-reward research focused on early detection and interception, therapeutic development, and personalized medicine. Special thanks to our sponsors, AACR, Clearnote Health, Exact Sciences, Merus, and the Gloria J. Rosenthal Memorial Fund. We appreciate your support and are grateful that you are in our corner. A huge thank you to David Tuvison, Elizabeth Jaffe, Andrew Rakeman, and the entire Lustgarten staff for making today's symposium a reality. We are at an inflection point where we're seeing tremendous advances in pancreatic cancer research, and we're moving at a pace faster than ever. And our efforts at the Lustgarten Foundation are strengthened by the clinicians and scientists you will hear from today. We're so glad that you're here to be part of this important and very special day for the foundation. Now, I'm pleased to introduce Dr. David Tuvison. As our chief scientist, Dr. Tuvison is Lustgarten's North Star. Dr. Tuvison is a physician scientist with a long-standing interest in the understanding of pancreatic cancer. He is the director of the Cancer Center and the Roy J. Zuckerberg Professor of Cancer Research at Cold Spring Harbor Laboratory, and recently served as the president of the American Association for Cancer Research from 2021 to 2022. Please give a warm welcome to Lustgarten's chief scientist, Dr. David Tuvison.
Okay, good afternoon, everybody. Thank you so much for coming to our 25th anniversary event, especially to my colleagues in the field who have extremely busy jobs, and to all the patients, patient advocates, et cetera, and researchers who are fighting this disease. Now, in terms of the North Star analogy, I look at the sky at night a lot. Sometimes I'm on the water, and so I look for the North Star. And I think finding the North Star is important. Biblically, that's how people moved. And so today what we're going to do is use the stars to find the manger. And in the manger, we're going to look for the three gifts. And the gifts are really going to be the talks that you're going to hear today from some of the best authorities working on this disease. So pancreas cancer, when I started as an oncologist more than 25 years ago, was one of the 4 cancers for which people didn't want to work on. They didn't want to think about it. They didn't want to talk about it because there was almost nothing you could do for a patient. And you were discouraged by your attendings to go into this area. Today, that's different. Some of the best and the brightest physicians and scientists are going into this field. It's an active, enthusiastic field for which we have things to offer patients because of the thought leaders who've really worked hard along the way. We know a lot about the why of pancreas cancer. Why does it happen? The processes that occur in cells that lead to a malignant state. We know quite a bit about the cells around the cancer cells. And we have ideas of targets we would love to obliterate to make the disease manageable. And we're starting to see that concept in the clinic today, which is fabulous. We have terrific investigators who work on immunology, who have had a hard time in the past, who are now having a better time because of all their knowledge that's been translated along with our understanding of this disease. And you'll hear from my colleague, Dr. Elizabeth Jaffe, who is the chief medical advisor to the Lustgarten Foundation, and she'll give her perspective on where we are today and why we do see a light. It's not just a dark path. We see light at the end. And that's what's really exciting. And so 25 years ago, when this foundation was started, it was for the same reason that a lot of cancer research foundations are started, because we lost someone. We lost Mark Lustgarten, who I didn't know personally, but I do know his son very well, Andy, who's the chair of the board of the Lustgarten Foundation. And the commitment of the foundation for the last 25 years has been to use science to deepen our understanding so that we can be more impactful with all of our efforts towards helping patients with pancreas cancer and help people from becoming patients with pancreas cancer. And so, I have found my dozen years working with the foundation extremely meaningful in that way. And so my job is to moderate the first session. The first session is going to be on the early cancer, the pre-cancer phase, and about the understanding what early cancer is, detecting it when it's early, intervening when it's early. And again, I'm blessed with having 4 terrific speakers who will address this. And the way this is going to work is we have these 5 very attractive chairs up here, and they will look more attractive when the 4 speakers are up here. They're going to, give some comments while they address their different themes, and then we're going to have a round table at the table. So the first session is going to be started out by Brian Wolpin. And so Brian is the director of the GI Oncology division at Dana-Farber, and that's the Hale Family Center. He's also the Robert T. and Judith Hale Chair in Pancreas Cancer at the Dana-Farber and associate professor at Harvard Med School. He's a medical oncologist and a clinician investigator, and he's someone who actually sees patients a lot, who understands the science deeply. And he's figured out how to collaborate with terrific scientists at Dana-Farber and Harvard and MIT, et cetera. His research really focuses on stratifying patients. Who's at risk for developing this disease? The folks who end up with diabetes when they're older, that's not the usual type of diabetes, the individuals who lose a little bit of weight more than they should be doing, and other sorts of risk factors that he will talk to you about. And he's developed mathematical models for thinking of that, which help all of us look at this, from a different lens. And so I'd like to invite Brian up, and I look forward to his lecture for us today. Brian.
Right. It's great to see everyone. I want to just thank the organizers for inviting me. I'm really quite honored to be here, given how much just tell me where I have to hit, how much the foundation has meant to the field and then really to my own career. So as Dave said, I'm a medical oncologist at Dana-Farber. One of the things that we do is we think about who is at risk for this disease to try to use then approaches to find this disease earlier. That's the aspect of the work that we'll talk about today. Excellent. This. Okay, great. All right. Okay, so we'll jump right in because I know we have a lot of really amazing speakers today. So really just one slide that I think everyone is well aware of. Pancreatic cancer presents late, right? So what you can see is over half the time it's metastatic at presentation. See my pointer? Yes. And then another quarter of the time it's locally advanced where we can't do surgery, right? And these patients do not have long-term survival, right? Almost uniformly. If though we can find the disease early, stage 1 pancreatic cancer is found about 5% of the time, then survival and long-term survival is much better. And so part of the question here is, how do you identify people earlier with this disease? So there are a couple groups which the following speakers are going to talk a lot about and have a tremendous amount of expertise in, which is familial and genetic risk for pancreatic cancer and cystic lesions. And these maybe account for up to 25% or so of pancreatic cancer. But part of the problem is there's this big group here of 75% of people who don't have these things, right? And so they are not getting any type of surveillance or imaging or testing in order to identify pancreatic cancer early. And I thought what I would talk about today is how we think about that group. So if we start off with just what is risk stratification, why is it important? So just the concept, which you're likely familiar with, is really a process to try to identify and predict a person's risk level for a disease, and then how that relates in the population as a whole. So how do you take a population and understand what someone's risk is? And this is important because it really helps us then think about the performance of tests that we do to find cancer early. These can be blood tests like ctDNA, they can be imaging tests, right? Many times these tests are described in terms of population-based metrics like sensitivity or specificity, right? Sensitivity being the proportion of people with a disease who present and have a positive test result, and specificity being the proportion of without a disease who have a negative test result. These are very useful concepts. They help you understand how the test functions, but you need to already know in the population who has the disease and who doesn't. And that's not what you are faced with when you're a clinician in your office or a patient getting a test done. That's really, if you have a positive test, what's the likelihood you actually have cancer or whatever condition? And that's your positive predictive value. That's a personal metric, right? That if you're sitting in the office, you get that result back, you then make a decision for a patient in front of you. And really that is dramatically altered. So the likelihood that a positive test means you actually have the disease is dramatically altered by the prevalence of the disease in the population you screen, right? So the higher the prevalence in your population, the higher positive predictive value will be. And I thought I would just illustrate this briefly to describe this in terms of populations we think about, right? So if you look among individuals in the US greater than 50 years of age, anyone across the whole population, the risk of pancreatic cancer is only 0.04% per year, right? A very low risk. And so you can see, even if you have a very good test, right? High sensitivity of 90%, high specificity of 99%, the positive predictive value is still quite low. So still, if I get that test back in the clinic, I know my patient probably doesn't actually have cancer as opposed to does. But as the prevalence of the population you screen goes up, so 0.4%, so like another, say, 8 to 10-fold increase in risk, another 4% or up to 4%, another 8 to 10-fold from there, which are populations we see, right? You can see that the positive predictive value, when you keep the test exactly the same, right? Same sensitivity, same specificity, same test, right? The positive predictive value rises quite quickly. And so really part of the question is, how do we find populations where the risk is higher, right? The familial risk group is one of those that I know Mimi's going to talk about. So how do we think about that? And again, this group of people who don't have familial risk or genetic risk. So you can think about this as, well, we know that there's a bunch of risk factors, sort of individual factors that are related to risk. Smoking is one of them, but that relative risk is about 2-fold or 2.5-fold if you're a heavy smoker. That by itself, not sufficient, right? That will not increase the risk in that group high enough that your test performance will be sufficient to roll this out in a large way, right? Quite different from lung cancer, where this is used every day, right, to make screening decisions. Well, what if you start to put together a lot of factors that are risk factors, right? You say, oh, well, we don't only know smoking, we know obesity, and we know some of these others. What happens if you put all of those together into a model? And there have been a number of groups, including our own, that have tried to do that. That unfortunately also does not seem to convey enough risk in aggregate to find a group that has a high enough prevalence for screening, okay? The other piece to this is, and this is work done by Chen Yan, who's a very talented instructor in the group who has a poster outside. This also doesn't take into account a lot of the complexity of how these different factors interact with one another, right? So to the left is a study that she did recently where she just asked a simple question, which is, how does risk for pancreatic cancer related to risk factors change as you age? It turns out it changes a lot. And so just saying someone's a smoker is very different if they're 80 versus 50 and what risk that conveys. And most of the models we use don't take into account this sort of complexity, the heterogeneity in how risk factors matter in terms of risk. To the right is another paper that she published a couple of years ago that really emphasizes the importance of time, right? So it's not only the risk factor you have, but when did you have that risk factor and how does it relate in time to other risk factors, right? The interactions between these factors over time really matters when you're trying to understand risk and find a population that have a high enough risk such that a screening approach would be useful. So the other piece to this, I think that we've been thinking about more recently, is there's also all these things that happen to patients in the 1 or 2 years before their diagnosis, right? When you're an oncologist and you sit in clinic and you see these patients week after week after week, you realize the symptoms didn't start a day before they were diagnosed. In some instances, they started a year before they were diagnosed, or even a little bit longer, right? The hyperglycemia that's caused by pancreatic cancer can actually happen 2 years in advance. And so how do we start to take some of these pieces of information into account also, in addition to what's considered a classical risk factor? So we did a study recently where we tried to incorporate some of this just to try to proof of principle that this idea would be useful. And this was a study where we basically asked people their medication use every 1 to 2 years over decades, right? And then we made a matrix of what medications changed over decades within each 1 to 2 year period. And we asked, if all you knew was someone's medications, could you predict risk of pancreatic cancer based on the changes, this matrix of changes that occur? It turns out you could. In fact, you could get relative risks as high as 5 or 6 just by knowing medications. And really what we thought, and we have a couple other papers that are similar in concept to this, is this reflects, again, what's happening to the patient in the year or two before their diagnosis. And the idea that we don't only want to rely on the risk factor that could increase their risk over 2 decades, there's all this stuff going on in the year or two before diagnosis that could be useful. So where did this go? This is sort of my last group of slides. Where did this take us? So ultimately what we decided that the place this should take us is the electronic medical record, right? Where all of us who see patients put in tons of data all the time. Sometimes it's the bane of our existence, right? Getting all our notes and all this stuff done. But there's a ton of structured data now. There's some unstructured data. And concurrently, there's been a lot of advancements, as everyone knows, in machine learning approaches. So how do we combine these two things, use all the data that's there and the pattern recognition abilities of machine learning to understand risk? So this actually started with a grant from the Lustgarten Foundation and Stand Up to Cancer. It was a grant that was led by Chris Sander, who's a data scientist at Dana-Farber, and Søren Brunak, who's in Denmark, which was very useful because the National Health System of Denmark was a great place to start looking at this and testing these approaches. And so the way we started was just asking something we thought would be simple to begin with, but docs in the audience know it's not so simple. ICD codes, right? So the billing codes we use, right, which turn out to be quite complicated. But now there are many, many tens of thousands of these codes that are being put in the record all the time, right? And really the question we wanted to answer is, could you have a time sequence of these codes that might predict who's going to get pancreatic cancer? Right? And that's what this study did. So we had a large population, millions of people in Denmark. We could divide it into different sets, training and development and testing sets. And then we could use a number of different machine learning approaches to look at trajectories. So this is a trajectory. Each one of these green circles is some ICD code that went into the record. It could be a symptom, it could be a diagnosis, it could be an admission, it could be all different things. And some of these people, say the triangle, go on to get pancreatic cancer and most don't. So how do we set up a model that predicts who's going to get pancreatic cancer, which was the goal of this study? And we learned a lot of different things. I'm not going to go through the data in detail. We learned a lot of different things, though, as we were doing this. It was a great sort of test playground for us to work with these data. Part of it, some of the things we started to think about is how far back do you want to go? If you have 30 years of data, how much of these data do you want to use to generate these models? How far forward do you want to go? Meaning, what do you want to predict? Do you want to predict 3 months, a year, 5 years, right? That has different implications then for what you'd have to do with that information. And then what about the information that happened, like where ICD codes are entered in the month before they were diagnosed, or the 2 months? Is that really useful for early detection? So how do you think about excluding some of that really near-term data? And then I think a really important one is, how do you take these models? How transposable are they between health systems? Right? If a model works in one health system with a particular kind of ICD code sort of milieu, how does that work in another? Right? And I don't actually have the exact answer to that yet. It's something we're still working a lot on. So I thought to finish, I'll just simulate. We did this in the manuscript, which is we tried to say, let's simulate how this might work, right? So if we're actually going to try to do this, because obviously as an oncologist, we don't want any of this to be an academic exercise, right? We're seeing way too many patients in clinic with metastatic disease every day. So the way we modeled this was, let's take 1 million people, theoretically, 1 million people in a health system. They're 50 years or older, right, in a population. And let's ask, well, how many cases would you get if you have what would be considered sort of the standard US risk? You would get 400 pancreatic cancers in a year in that group of 1 million people, and 999,600 would not, right? Would not get pancreatic cancer. So then we would use the model, and this is actual data from the model we built in the Danish system. We would use the machine learning model from medical records using ICD codes, and we sort of somewhat arbitrarily, but to start to think this through, said, let's take the group that's in the top 0.1% of risk predicted by the model. right? So that would mean 1,000 people would be taken aside and said, you have at risk for pancreatic cancer, and 999,000 would not, right? They'd be left in the standard risk group. So then what does that mean? Based on the functioning of the model that we use, this was a model that predicted 12-month risk of pancreatic cancer and removed 3 months of data before diagnosis, again, so that we weren't using ICD codes that were right up against the time of diagnosis. And what that was able to do is pull out of the 1,000, 100 of those were the ones that were getting pancreatic cancer. So you've gone from a point where you have a population rate of 0.04% now to a rate of 10%, right? Which now is a population you could screen, right? With whatever, again, ctDNA, imaging, what you prefer. It doesn't mean though that you found all the cases, right? You certainly haven't, right? You can see among the 999,000, right? There are still 300 cases that occurred. The population rate in that group goes down a little bit, right? It's now 0.03% because you've pulled out some of the cases. But the way you tune these models and set your thresholds, you can choose this, right? How many of these false positives are you willing to tolerate to find one case, right? And that's something that you can build, again, as we think about these models. So in the forward-thinking part, and I promise this is my last or second to last slide. So if you sort of think forward, you know, how do we think about this? The way we're trying to think about this is lots of data, right? Medical records have a tremendous amount of data in them. Some of them are risk factors. Some of them are a consequence of the disease. These data need to be used, right? We're not using them for, I think, all of the ways they can be used to help patients. We particularly want to use them to find who is at risk for pancreatic cancer in the 75% that Mimi and Anne-Marie and Peter aren't already, you know, following and finding cancer. And then we want to be able to stratify them into risk groups where we can say your risk in the next year is X%. Because of that, we should do a ctDNA test. Or your risk is so high, we need to do what Mimi has pioneered, which is we need to do an MRI, right, to look for this, or an EUS now, because your risk is high enough, we think that's justified. Ultimately, we think this is a potential, a lot of hurdles, right, to get through, but a potential way to address, again, the general population for which screening so far we've been unable to do. So I would just really, again, thank the Lustgarten Foundations, and really just a tremendous congratulations to the foundation, really for 25 years of incredible impact and progress for patients. So thank you.
Yep, thanks so much, Brian. That was great. So the next speaker will be Dr. Mimi Canto, who runs the endoscopy service at Johns Hopkins. She's a professor of medicine and a gastroenterologist, and she's conducted a study over the past several decades, actually studying high-risk patients very carefully. And she and her colleagues, including Mike Goggins, have reported that careful surveillance of these patients can lead to much better outcomes, as I'm sure she will regale us with today. So we were really lucky to have you with us today, Mimi. Look forward to your lecture.
Good afternoon, everybody. It's really great pleasure, and thank you to Lustgarten for the invite. Just as they mentioned about a personal connection, and the personal connection I have with pancreatic cancer is as a young first-year faculty at Hopkins, I put a biliary stent in a patient who was jaundiced from a pancreatic head cancer, and I went out to talk to her daughters, and her daughters asked me, "Well, what about us?" And they go, "What about?" "Well, our whole family has pancreatic cancer, and my mom is the 6th one in our family over 3 generations." And I thought, well, there must be something we should be able to do and learn about, right, in families that are at risk. And so that's what kind of started my journey in familial pancreatic cancer surveillance. So I want to give you, in the short time I have, just what we've accomplished and sort of moving forward, seeing beyond what we can accomplish further on. So we all also are at 25 years of pancreatic cancer screening and early detection, literally 25 exact years since we started. We started with actually figuring out who are the people at risk. And at the time, it was familial pancreatic cancer, which we defined as a pair of first-degree relatives in the family related to the person being screened by first degree, like a parent, sibling, or child. And then it expanded to patients with mutations who were not affected by cancer. And so it grew over the many years. And initially, we did not know how to even begin. We thought that maybe endoscopic ultrasound is a very unique tool that can visualize the pancreas with very high frequency. And this was the way to start. And over the years, it then involved MRI as another clinical imaging tool that we've studied. So here's the timeline of the CAPS, cancer pancreas screening studies from 1998 to current. It's the longest running surveillance program in the world. You can see here that we've rolled over to about now 2,000 or more patients. We've discovered or at least detected about 26 cancers who are asymptomatic in the surveillance program. And fortunately, again, the goal of this program is to really aim high to detect and treat stage 1 cancers or even the precursors before they become cancer. So really high bar. I want to be able to thank the Lustgarten actually that funded CAPS-3, which is really in my second year of my journey here, that funded this important CAPS-3 study that we published in Gastroenterology that really was part of this journey. So what did we learn? We learned that pancreatic cysts, most of them are actually IPMNs and PANNs or incipient IPMNs. When you start, they're very common in high-risk individuals. Almost half of the people have one of these. And these are actually what we discovered, that these are actually pretty detectable by EUS. They occur in a milieu that is really unique. There's some funny changes in the pancreas that we see. This is the pancreatic duct here. These are the tiny cysts that we can actually see and measure. And there's these lobularity, we called it at the time, heterogeneity that we couldn't figure out at the time. And we actually took some patients to resection because there were lesions that we were worried about. We discovered that in fact, these tiny cysts are the precursors to cancer. Pannins, microscopic duct precursors, or incipient small formulae IPMNs. And they all, again, were quite worrisome, but invisible to mostly our eye. Then we found out by following patients over the years, we learned more about the natural history of progression in these individuals. This is an example of a patient who had 2 first-degree relatives. Baseline had small cysts, moderate chronic pancreatitis by EUS. 7 years later, very subtle dilation of the duct, no mass. And 1 year later after that, had a Whipple for an IPMN-associated cancer. So this is almost an evolution, almost like Dave Tuvison's model of carcinogenesis, but this is in humans. We actually watched this occur over time, and we learned a lot. In fact, we now are learning how we can actually probably interrupt this whole process at some point. And interesting is this patient who is, this lady here, is actually still alive 6 years later after her Whipple, and her other sister who was detected in CAPS also is alive 10 years later from early detection. So a prime example of how early detection can work. We also learned that progression is occurring as we get older, the risk increases, but the timeline is long and there's a big window for interrupting this, an opportunity for early detection and prevention. So the timeline from baseline to developing progression to cancer or high-grade dysplasia is about almost 5 years, a window of about 1 to even 6.5 years when you're under surveillance. And we found that independent risk factors for progression in this cohort is age shorter than 60, multiple cysts, many of them are pannins, a dilated pancreatic duct, very, very minimal dilation, and obviously carriers of genetic mutations. What we've now accomplished is that over time, we found that we can actually increase significantly the number of stage 1 cancers from about 5% to almost 39% in this cohort. This is really unheard of. We also minimize the number of metastatic diseases, and we actually increase the number of resectable cancers when they're under surveillance. And we compared the patients who actually were in the CAPS program but fell out. This is this red line. Obviously, their survival was not as great as those who actually were detected in the cohort, and even better, the patients who had high-grade dysplasia at the time of surgery, all alive 5 years later. So in fact, the underscoring the potential for preventing cancer and improving survival. So in this recent analysis that we just submitted, we compared our 26 patients who developed cancer. These are incident cancers in the program versus the matched SEER controls in America. You can see here by the red line that in fact, we actually have moved the needle forward. You can see that the median survival rate we can quote is now 5 years compared to 0.7 years in the matched SEER group. 5-year survival now quoting 50% people alive at 5 years, which is unheard of in any other unscreened population. When you look at even resectable patients, the bar is even higher. Median survival, 12 years. This is curative treatment for these patients compared to 1.9 years in controls, and 5-year survival rate of 61% in these patients with cancer that is resectable at the time of screening and diagnosis. So here's the example of one of our patients who was a surgeon referred himself for screening, 5 affected members. Tiniest pancreatic cancer we found, 7 millimeters, had a total pancreatectomy. Here it is. And you can see him every year. He sends us an email about his trips and travel over the world. He hikes in Normandy. He bikes all over the place. And this is his 80th birthday this year. And he's always forever grateful for what we've done to save his life. Now, this is a great story, but what are the challenges? There still are a lot of challenges that we have to face and opportunities that I talk about. First of all, we detect all these lesions. What do we do with them? When do we operate? These are really, really key important challenges because it's hard to take someone to surgery for a total pancreatectomy who's asymptomatic, right? Well, we know that the worrisome features that we use for IPMNs, which Dr. Lennon will talk about, they don't apply to high-risk individuals. These people have smaller cysts. They don't have worrisome features. And in fact, when we see what we use for our IPMN patients nowadays, they don't apply to our high-risk patients. For example, this 80 millimeter really innocent branch duct IPMN by EUS. Basically, we took aspirated fluid, we did pancreas-seq, looked for molecular changes, all negative. But when she went to surgery, there was an IPMN high-grade dysplasia that actually would otherwise not be detectable or known, be found. The other opposite way is that we find lesions that are really clearly like cancer. This again, looked like that small cancer I showed you. Positive FNA, suspicious for cancer, went to surgery. It wasn't a cancer. We tell the patient, hey, good news, you don't have cancer. And he was so happy. But we feel, well, maybe we could do better, right? This is actually a false positive lesion. Nodules associated with these PANN precursors form into a little cluster that look like cancer because of this lobulocentric atrophy that occurs in relation to these PANN precursors that we now learn are very prevalent in these patients. Another missed opportunity, pancreatic protocol CT at Hopkins, best CT, 60 millimeter branch duct IPMN, tiny cyst, nothing to do, continuous surveillance. 1 year later, looks very stable. But when you look closer at it, there actually is already a PDAC in this lesion with duodenal invasion. I'm hoping that the Felix 2 project supported by Lustgarten will continue to make progress with CT and AI improvements in diagnosing these lesions more appropriately and more accurately. So these missed PDACs are really a problem because we can see in RCAPS patients that there are still in interval lesions that are missed. They turn up between screening intervals roughly a year apart. And are they false imaging, negative imaging, or this is just rapid progression? We don't know what it is. But how can we do better, right? Well, here's one way we're developing with my partner, Doc Goggins, a way we can use a very common tumor marker test called CA99. It's not very good because it's lots of false positives, false negatives. But Mike and his lab developed a genotype test where we can actually use personalized levels of your own enzyme or to create your own levels of serum CA99. So we do this once in the lab and we follow CA99 levels forward. And you can see here, these are the 4 different functional groups depending on your genotype. This is the normal cutoff. You can see there's lots of ways that you can have false positives and false negatives if we don't have a personalized level of this marker. And in fact, this paper that was published last year, you can see here, we can actually, with genotyping, improve the performance characteristics of CA99 with genotyping. We're an AUC of 0.92 for all cancers and even 0.86 for stage 1 cancer. This is amazing given that this is such an inexpensive, commonly available tumor marker. So finally, I want to shift gears into AI, which you all know is such an exciting way to augment clinical decision-making and make us learn more about early detection. At Hopkins, in collaboration with our computer science scientists, they've developed a deep learning segmentation tool that can automatically use scanned images of pancreatic resections and basically classify all the structures in this lesion into 10 different structures: pannin, normal ducts, fat, atrophies, fibrosis. And so basically this allows us to really understand better the microenvironment and the anatomy of pancreatic cancer and its precursors in individuals, not just high risk. So you can see some of these pannins, these are the colored things you see here in this video, are long and tubular and branching. Some are typically small and simple. And so again, this is what we have to understand in terms of where does it start? How do we understand how this looks on clinical imaging so we can learn more and improve our diagnostics? So here again, it's a coded representation of normal ducts, the fat and the pannins that we can see in these slides. And in fact, this is just preliminary data, when you compare the structures of pannin and its associated lobulocentric atrophy in our high-risk individuals, clearly more pannin burden, more fat and atrophy. And in fact, this translates to increased fat content by MRI that correlates directly and strongly with quantitative fat by histology. So again, this is an exciting potential new marker that we can follow by routine MRI. Finally, another exciting thing we're working on now is heterogeneity in EUS images. So you can see here on the left, normal pancreas, very homogeneous. And on the right, this is what we see typically in our high-risk individuals. Lobularity, we couldn't understand why they have chronic pancreatitis. They're not alcoholics, they don't drink. But in fact, these changes translate to all this lobulocentric atrophy and fat that we see related to pannins. So here again, very, very early work where we analyzed 40 patients who went to surgery, and we looked at their EUS images. We extracted them using radiomics techniques, and we classified patients according to those who progressed and didn't progress. And just very early work, you can see there 83% prediction of progression in the non-lesional pancreas before they diagnosed with cancer. So again, very easy way to use AI and deep learning to help us predict patients who progress. So finally, the last slide, what is the view? What is the goal? The goal is to actually use what we have now, clinical demographics, age, family history, genetics, and routine imaging, and incorporate it into our routine surveillance of these individuals. We want to use AI, use high clinical predictors of progression, use deep neural networks, and allow us to incorporate this into our decision-making about how to take care of our patients and ultimately help continue to move the needle forward for early detection. So I want to just thank you all for listening. I think we've shown that we actually have moved the needle. We can diagnose more stage 1 cancers. We actually have improved the survival by 2-3-fold. We now want to look at combined imaging with AI to continue to make progress. Thank you very much.
Thank you so much, Mimi. So our next speaker is Dr. Anne-Marie Lennon, who's also at Johns Hopkins. She's the Division Director of Gastroenterology and Hepatology, and she's the Moses and Helen Golden Paulson Professor of Gastroenterology. Dr. Lennon really focuses on the cysts. Cysts are common, and so actually trying to discriminate between a cyst that will degenerate into a malignancy and not as an extremely important problem. And so she's really focused a lot of her career on trying to understand patients with cysts and stratify the patients using radiologic molecular approaches and possibly machine learning, as everyone seems to be using these days. And we're really looking forward to her lecture. Thank you.
I'll take this, it's fine. Wonderful. Well, thank you very much. It's really, it's an honor, but also a great pleasure to be here. So once we get the slides up, I have been given 10 minutes and I've been told I need to stick to it. So over those 10 minutes, I am going to touch about a couple of things, but what are the opportunities, but also what are the challenges that we face with pancreatic cystic lesions and the opportunity to diagnose pancreatic cancer earlier. And I have no disclosures that are relevant to this presentation. So let's start off with what are the opportunities with pancreatic cystic lesions. Well, we start off with there are 3 precursors to pancreatic cancer, as we've shown here. And if you look at this, 2 of the 3 precursors, mucinous cystic neoplasms and intraductal papillary mucinous neoplasms, are pancreatic cysts. And I think if you're lucky enough to have a Mimi Canto, you're working with Mimi Canto, then you may be able to pick up pannin lesions. For most of us, they're actually very difficult to identify. But in contrast, you can see here, pancreatic cysts are easy to detect and give us a unique opportunity to screen for pancreatic cancer. Well, I've spoken about what are the opportunities, but you notice in the title of my talk, it was challenges as well. So what are the challenges? And there are a number of challenges that we face. So the first one is that not all pancreatic cysts are IPMNs and MCNs. And when we see a patient with a pancreatic cyst, what we want to understand is, 1, what type of cyst do they have, so we can appropriately tell them what management they need. Do you have a patient with a benign cyst, such as a serous cyst or a pseudocyst, whom we can safely discharge? Do we have a patient with one of our two precursor lesions, an IPMN or an MCN with low-grade dysplasia, where we can tell them, let's follow you with surveillance? Or do we have a patient with an IPMN or an MCN with high-grade dysplasia or early pancreatic cancer whom we need to send to Dr. Allen? So this sounds so simple, but it's not. And if you look at large surgical series, 17% of patients who undergo surgical resection are found to have a benign lesion. And in hindsight, they didn't need that operation. I think the hardest thing to do is to identify high-grade dysplasia or early pancreatic cancer in IPMNs and MCNs. And I think the challenge, you can see the challenge in this, and this is a recent multi-center study from some of the top centers in the United States. And what you can see here is in patients with branch duct IPMN, almost 73% of the patients who underwent surgical resection were ultimately found to have lower intermediate grade dysplasia. And in hindsight, at that, had we known, we could have prevented that operation. But hindsight is a great thing. So how can we move forward? And this is, I think, one of the most important studies. And this was led by Bert Vogelstein and Ken Kinsler. And what they showed was that there's a huge opportunity because different types of cysts have different mutations associated with this. So if you look here at the top, you have the commonest benign cyst, a serous cyst. They have a mutation in von Hippel-Lindau or VHL, and it's unique and occurs almost exclusively in serous cysts. If you look at our IPMNs and our MCNs, they have mutations in KRAS and RNF43, and our IPMNs have are associated with a mutation in GNAS, which again occurs almost exclusively in IPMNs. And these mutations can be detected in pancreatic cyst fluid. So we can send a patient to Dr. Canto, she can stick a needle into the cyst, she can take the fluid out, and we can now find these mutations in the cyst. In addition, we know some of the mutations associated with high-grade dysplasia or early pancreatic cancer in IPMNs and MCNs. Shown here are the mutations that are currently available in clinical care. So we can actually go and send the fluid for these tests. But there are many other markers that are out there that are very promising. And I hope that many of these markers in the near future will come into clinical practice. I'm a clinician, so this is great. But what I want to know is, does it work in real life? And does it change patient management? And the answer is yes. We now have more and more data coming through showing that these markers work. You can see here that the presence of a VHL mutation has exquisite specificity for the presence of a serous cyst, which is a totally benign cyst. If your patient has this, you can say, great news. You don't need to worry about pancreatic cancer. Your risk is the same as a person walking down the street. We don't need to follow you. The presence of a GNAS or a KRAS mutation has a very high sensitivity and specificity as shown here for an IPMN. And finally, we have real life data on how do these markers work in real life. So there's a recent study that was published within the last 12 months, which looked at almost 2,000 patients who were enrolled in 31 centers across the United States. And what they show is that if you have one of these mutations, you have 89% sensitivity and 99% specificity for the presence of high-grade dysplasia or cancer. But how do they work and how does it compare against current clinical care? So this was a study looking at just over 860 patients, all of whom went to surgery. And it compared the molecular markers combined with clinical features against current standard of care. And what you can see is that the markers were able to identify patients with a benign cyst 60% of the time compared to 19% of the time for current care. If you look at patients with IPMNs and MCNs, you can see that almost 50% of the time they correctly identified the patients compared to just over 30% for current standard care. And if you look at patients with IPMNs and MCNs with high-grade dysplasia or cancer, you can see that both current clinical care and the markers perform well, identifying almost 90% of the patients. And in this study, the use of the molecular markers could potentially have identified patients with benign cysts, such as serous cysts, or patients with IPMNs or MCNs with low-grade dysplasia, who potentially didn't need surgery. And so we could have potentially reduced the number of unnecessary surgeries by 60%. So as we look to the future, one of the challenges as doctors, Dr. Wolpin presented it beautifully earlier, there was all of these features. Did you notice that on his slide? There were all the different features. There was the clinical features, then there was a past medical history, then there's a family history, germline genetic mutations, CT, MRI, EUS features, CA19-9, MCED markers, not to mention all of these molecular markers. And one of the huge problems as clinicians that we have is that to analyze and to evaluate all of these markers, it relies on a huge amount of knowledge, and this is not something that you can do across. This is something that you need to come to a tertiary referral center. And that's, I think, not what we want for the future of medicine. So as we look to the future, many of us have talked about AI. And I would say that we need to leverage AI to better understand pancreatic cysts and management decisions. So at the moment, many of our patients travel huge distances to come and see experts in Boston and other places to get their opinion. And I hope in the future, instead of that, our patients will be able to go into their primary care physician, their local gastroenterologist or surgeon, and that AI will be able to take all of those different features and will be able to give us an output, something like this, telling us for our patients and their doctors, what is the probability of what type of cyst you have and what management should you have. That we're going to have glass box models, which will allow the physicians to understand what are the features that drove that probability and to make sure that it makes sense. So over the last 10 minutes, and I promised I would keep to 10 minutes, we have spoken about the opportunities and some of the opportunities and the challenges for detecting pancreatic cancer earlier through pancreatic cystic lesions. If we look at the SEER data in 2023, this is what we see. Over 50% of patients with pancreatic cancer in the United States present with metastatic disease, 29% present with regional, and only 13% present with early, potentially curable disease. And if we truly want to change the outcome and the survival of patients with pancreatic cancer, we need to shift that graph where we diagnose the majority of patients with early disease. So I'm going to finish by sharing data from a prospective study that we've performed at Johns Hopkins, following almost over 2,000 patients with IPMNs. And what we found was that in these 2,000 patients, 7% developed high-grade dysplasia or cancer. The first thing you can see that we've been able to shift the graph from 51% of our patients being diagnosed with metastatic disease to 71% of the patients being identified with high-grade dysplasia or stage 1 cancer. And that's great. But the other thing you're going to see on the graph, which as a clinician who cares for these patients, I think is one of the hardest things, is that 16% of the patients who were under surveillance presented with stage 3 or stage 4 cancer. So I think in summary and in conclusion, I hope I've shown you that pancreatic cystic lesions, specifically IPMNs and MCNs, offer an opportunity to detect pancreatic cancer earlier. We have made a lot of progress, but we still have further to go. I'd like to finish off by acknowledging the many groups of people across the country and around the world who've been involved, we've had the opportunity to collaborate with. I want to specifically thank the Lustgarten Foundation. Without your help, we would not be able to do this work. And then I want to recognize the many individuals in the Lustgarten lab at Johns Hopkins who have led this work, and in particular, Bert Vogelstein, Ken Kinsler, and Nick Papadopoulos. Thank you so much.
Okay, thanks so much, Anne-Marie. So the last of our speakers for this first session is Dr. Peter Allen. He's the David Sabiston Professor at Duke and Chair of the Department of Surgery and also lead surgical oncology. He's also the developmental athlete in the ALPS program. And so Peter actually established the tumor bank at Memorial Sloan Kettering when he practiced there for many years. Where he very carefully cataloged the many patients that were operated on there, collected the tissue, had all the information about the patients. That has become a real terrific reservoir for many other physicians and scientists at Memorial and elsewhere. And we'll hear from one of his trainees later today who's used that to great distinction. Peter has focused also on cystic disease, having this question that was posed to us by Anne-Marie, who to operate on, as well as could we do something to change the natural history of patients with CIS, particularly IPMN. He's a member of the advisory board at the Lustgarten Foundation and a terrific source of inspiration and advice for myself. So Peter, thank you very much.
Thank you. Good afternoon. It's wonderful to be here. I always learn so much at any Lustgarten event that I attend. It's just a terrific group of people who are committed to trying to battle and defeat this disease. So it's a real pleasure to be here. I'm going to make a pitch for Interception. Interception is a buzzword now. Many cancer centers around the country are developing their programs in interception. And so my pitch is to go from early detection to interception. This is the curve we've seen earlier. Vast majority of people with pancreas cancer present with stage 4 disease. These are actual data from the database that Dave mentioned in Memorial. So these are actual data, actual patients. The vast majority of patients we see have stage 4 disease. And this is just in comparison to breast cancer statistics, where this light pink bar up here is the small percentage of patients with breast cancer identified with stage 4 disease. So this is my slide for early detection. We just need to identify these patients earlier and we can solve our problem. This is my slide for interception. These are the same 985 patients treated at Sloan Kettering over those years. I agree these are dated statistics. I'll talk about that in a moment. But this is this actual survival outcome of those patients. And these 28 patients that we think are so lucky to have the earliest stage cancer, these are not screen detected cancers. I will admit that. These are not 6 millimeter, 4 millimeter cancers. These are 1 to 2 centimeter cancers, node negative, but this is the actual survival outcome of those patients. And Brian and I were sitting at a meeting a couple of weeks ago thinking about this, just saying, we're doing better now. We really think we are. And I do feel that. We are having anecdotes now that we have these long-term survivors. However, if we look at even recent data, and these are prospective randomized data from the PREOPANC trial, these are highly selected patients enrolled into a prospective randomized trial. And these are the survival outcomes of these patients enrolled, published in 2023, of just the patients who underwent resection. So this was a borderline resectable and resectable trial. These are not probably stage 1A cancers, but these are resectable cancers. And you can see there are a lot of sensor points here before 48 months. This curve can only get worse. And you see the actual survival of the vast majority of people who are diagnosed with pancreas cancer, not screen detected, not 6 millimeter cancers, but the 95% of patients that we see every day in the surgical clinics. So I think interception needs to be really considered and invested in if we're going to improve outcomes in pancreatic cancer patients. We've heard about the differences between IPMN and PANN, and my interest in IPMN really developed because this is a precancerous lesion that we can identify radiographically. I could talk for the next 3 or 4 hours about IPMN and have a lot of good fun. I will only do the next 8 minutes. But there's a lot of interest in these lesions and they're fascinating. And I would encourage all of you bright, young scientists out there to dig into these lesions because there is so much that we can learn about IPMN that can help us in patients with pancreas cancer. And this is a patient who had IPMN. It's a bit dated, 2012. He was found with these cysts out here in the tail of his pancreas. He had a EUS done. Cyst fluid CEA was elevated. He has IPMN. He was followed as he should have been. It changed in 2015. He should have had this lesion removed at that time, but he came to see me a year later with a clearly enlarged lesion. We removed it, and it was a 1 centimeter cancer, stage 1 cancer. This is a failure to me. It's a failure. Should have been removed before it became a deadly cancer, where he actually ended up dying of this disease 5 years later. He was a 5-year survivor, actually, so he would help those statistics, but he still died of this cancer. One thing I would tell you about IPMN, it is multiple diseases. It's very heterogeneous. We're learning a great deal about this now that we're having more powerful technologies, particularly the omics and spatial technologies that are coming to play here. But there are multiple different subtypes with different types of risk, some progressing to colloid cancer, which is a much better behaving cancer, many progressing to typical tubular cancer. What I would say is that I think the omics and the spatial revolution is helping us a great deal. These are just some pilot data from our group, where really these patients with intestinal subtype separate out nicely from gastric and pancreatic biliary, and likely gastric is simply a low-grade form of pancreatic biliary. And we're being able to group and subgroup these a little bit better. So I think we will also be able to stratify risk of these patients, because some of these patients have a real risk of progressing to pancreas cancer and many do not. And like Anne-Marie said, many of these patients we can probably put on the back burner. One of the things I would say we have been interested in is the presence of inflammation as these lesions progress to cancer. Olcha Basturk and Volkanadze, 2 pathologists, reported on this back in 2010 or 11 and showed quite nicely that as IPMN progresses to an invasive lesion, there becomes a significant amount of inflammation almost uniformly. We've also looked for this in the cyst fluid and think that these inflammatory markers can be detected there and potentially give us a snapshot into what is the immediate risk of these patients. And because of this thread, we really started on this pathway of could we potentially intercept and prevent progression of IPMN lesions to pancreatic cancer. And this is a study that we recently, or not recently launched, now 4.5 years ago launched, in an effort to see if we could prevent progression by inhibiting inflammation in the pancreas. I won't go into the many hours of conversations we had about what agents should be utilized. There weren't many sexy agents out there to use other than sort of an aspirin. And that's what we finally decided on was actually the use of Solindac for a variety of reasons as a potential way of preventing inflammation and progression in patients with IPMN. And so this is the 3PC trial sponsored by the NIH. It's a multi-center, randomized, placebo-controlled trial of patients with high-risk IPMN. I won't go into that definition in detail because of time, but it's a study being performed at Duke, Hopkins, MGH, and Memorial, where we're enrolling patients and randomizing them to receive either Solindac or matching placebo over a 3-year period of time. Those patients are being very carefully studied over those 3 years with annual imaging and annual EUS every 6 months. So it's a CT, EUS, CT, EUS, CT for a period of 3 years. And we're collecting samples and studying these patients carefully. So hopefully whether or not giving an aspirin or not works, we'll learn a great deal about risk and progression. Primary endpoint is IPMN progression as defined here, essentially growth of cysts or progression to pancreatic cancer. We were overly optimistic, thinking we could enroll 200 patients in a short period of time. This was not a good mechanism to support a randomized trial, an R01 funding mechanism, which is very time limited. Currently, we have about 75 patients enrolled, and our primary endpoints are essentially these specific aims: evaluating the effectiveness of Solindac, looking at the cyst fluid. So we're banking cyst fluid in these patients every year, Some of these patients are progressing. Some of these patients have actually developed pancreas cancer. And so we will have that fluid banked for analysis after this is finished. And we're also very interested in what Anne-Marie and Mimi mentioned around radiomics, and Elliot, who's a master, is helping to lean in on this and look to see if we can potentially identify changes on imaging in those patients who are progressing. So can interception be that simple? I'm not sure. I'm not optimistic about that, but I do believe this is an initial opportunity for us to build the framework around which we could test other means of preventing pancreatic cancer prevention. And we've talked about potential RAS inhibition, potential vaccine approaches, which I think will be more exciting in the future. So I would simply say that the principles for successful screening currently don't exist. But I think what Brian is doing to identify what's the high-risk group of patients is very important. I think what Mimi and Anne-Marie are doing in terms of identifying tests and screening tests that then could be applied to those high-risk patients is very important. And also our ability to actually develop effective therapies for these patients will be important, because screening involves all three of those pieces: being able to identify a high-risk group, having a test that can screen for that cancer, and then actually having a treatment that has meaningful difference in patient outcome. And because those are being developed now, I think marrying that up with interception and identifying the patients with high-risk precursor lesions and intercepting those patients prior to the development of pancreas cancer is a very valuable approach. Thank you very much, and look forward to more discussion.
Okay, so I'm gonna invite the other three speakers besides Peter to come up and take a seat. We're running about 20 minutes late, 10 minutes because we started late, 10 minutes because they're very enthusiastic. But what we're gonna do, instead of having a 30-minute discussion, is maybe do 20. And therefore we will recover time as this progresses. So the purpose of this part of the program is to allow the speakers to cross-examine each other, and also the audience to ask probing questions. And so since no one is jumping up out of their chair, I'll start. So we're trying to detect a layer of cells in a tissue, and I don't know of another neoplasia where anyone's looking for that. They're looking always for a mass, some type. What we're trying to do is detect it before it's a mass, essentially, is what I'm hearing. And I heard from Mimi that actually we could look for evidence that the small collection of cells has damaged the tissue around it, lobular central atrophy that you mentioned. And so, as Peter said in the end, it sounds to me like there may be some collaboration about to start. Brian's going to use the electronic health record, computational artificial intelligence approach to find in a general population people who are at higher risk. Mimi's already has a population in high risk that she's studying that carry a germline allele and a strong family history. But maybe look more deeply into the general population as well as the high risk population for any feature that jumps out quickly that tells us this could be a high grade pre-neoplasia, which is what you're all looking for, high grade neoplasia. Why don't we use things like proliferation? Essentially, if you're high grade, you proliferate more by definition, always. Panin-3, high grade IPMN. What I mean by that, for those of you who maybe come here to, not from a science or a clinical standpoint, is cancer is a problem when it makes more of itself. If it just sits there, it's an annoyance, but it won't make you sick. It has to divide to cause disease. And so why don't we think more from the imaging standpoint or the stratification standpoint of looking for some evidence of proliferation? Because without it, we probably aren't dealing with something that's going to be a problem. And so there are methods to look at for proliferation. Oncologists and radiologists have been looking at them for a long time, mostly in response to therapy, but I've never seen anyone do it for detection of high grade. So there's something, fluorothymidine, there are many more, I'd say, extravagant ways of doing it now. And so I'm asking a question I don't know the answer to, but I thought I would ask these guys, this great team here, so they could tell me I'm, imagining things or something they're doing or something maybe they could do if they had the right people, right resources, all that stuff. Okay, so it's a question to the team. Leaders should emerge.
Stop the answer.
I'll start so I can say something before everyone else jumps in. So we know that everybody in this audience has a Pannin lesion in their pancreas, right? Probably many. Very few of us, fortunately, will develop pancreas cancer. And so what is that inciting event that creates the pancreas cancer to initiate, progress, and become a metastatic lesion? I think that's the question. And can you differentiate those patients? I actually think we're finding some suggestion in the pancreas. I know that this is also being seen in patients with gastric cancer, as well as in breast cancer patients who have a high familial risk, that there is a dramatic difference between low-grade lesions in patients who go on to progress to cancer than those patients with low-grade lesions who never go on to progress to cancer, that the low-grade lesions themselves are different. If you measure proliferation, they'd be the same. But if you look at them transcriptomically and other omic assays for them, that they're different. And so what is that event? I don't know, but I do think we have the ability to stratify risk in the lesions themselves, even in the presence of a low-grade lesion.
I think, I think that we clearly need better markers to identify and stratify lesions. I think one of the problems is, particularly with imaging, is identifying tiny lesions. So you need to identify tiny lesions, and the ability of imaging to do that I think that's one of the huge challenges.
I mean, I was trying to think of clinical scenarios where we do that now, like Ki-67 staining in breast cancer, and using that as sort of a determinant, although there's some controversy about who needs adjuvant therapy as a marker of proliferation. My worry here is that the cell number is so small, like you were saying, that I'm worried there's not enough signal we will see, and wondering, are there ways that the signal can be amplified? And I've been sort of thinking, we have some studies ongoing, building on some things that have been said. The reaction to the tumor cells or the high-grade dysplasia in the normal pancreas may give you an ability to amplify the signal beyond just the cells themselves. But what's happening around them, right? What's the scar that's being laid down? What's the inflammatory process? And maybe that, together with markers that are tumor cell intrinsic, may help us. But I've been getting increasingly concerned over time that tumor cell intrinsic only markers will continue to be limited just by, as you said, the number of cells that are there and our sensitivity to detect them.
And just to add to that, I didn't have time, but I'm excited about the radiomics. 25 years, it took us this long to figure out what these changes are on these high-risk individuals. And they're amplified only in these people because they just have manyfold more precursors in their pancreas compared to the average person. It's like polyposis of the colon cancer risk, right? And what the thought is now, you look, as Brian said, at the effect of these small microscopic tumors on the pancreas environment, the milieu where it occurs. And there's not only fibrosis and fat, but there's also inflammatory cells. And in fact, this very exciting CODA, AI segmentation model that was developed is super exciting just to understand what that pathology is and to what extent all the different cell types play into the pathogenesis. So essentially, you're translating something microscopic into something that is basically radiomics features, at least if you're looking at MRI EUS as a signal. and then actually figuring that out on top of everything else about the patient. So it's not just that alone. It's the whole composite. We call it the holy grail: clinical, genetics, familial, plus radiomics and deep learning, of course.
Just get back to what Brian said for a second. In many ways, pancreas cancer is just any other cancer, right? It behaves like cancer, has stage-specific survival outcome. You detected it earlier. Patients do better. If you treat them systemically when they're at risk, you can improve out. In many ways, it's just another cancer. In many ways, it's a completely different cancer. Our bar to detect this cancer, to cure it, is unbelievably high. If you detect a 1 to 2 centimeter cancer in the thyroid or in the breast or in the colon that hasn't spread to the lymph nodes, you've cured the patient 95% plus. You do that in pancreas cancer and you haven't cured them. And in fact, the vast majority of them at some point, maybe not in the next few years, but will succumb from their disease. So why is that? So we have our need to detect this cancer is a very, very early stage. And we're looking for, as you said, cellular changes in the lining of the ducts that have high-grade dysplasia that can be very minute foci in a pancreas that's filled with pannin.
You have to flip the switch.
There we go. Thank you. So one of the most challenging of all the challenging issues we see in the clinic is when you do have someone who's being monitored in clinic for an IPMN or some other abnormality that's seen on radiographically. And then all of a sudden, 6 months later, they have metastatic disease, not primary. And I guess the question I have is, it sounds like from what you've all described and from what I've read, it's not, genetics is not the only indicator of what's going to be most likely to become metastatic versus just invasive. And getting to, I think Brian was alluding to it, when you look at pancreatic cancer, if you look under the scope, most pancreatic cancers look the same, but when you start to really think about the differences in the cancer-associated fibroblasts, the signaling, the metabolic changes, what's going on in the pre-malignancy looking at that? We do know that CAPs even play a role, at least in pannins in preclinical models, helping to shape, the aggressiveness of the pre-malignant lesion. It'd be interesting to know what's going on in this area to really better understand the microenvironment.
They don't disagree. The reason why I talked about FLT is because it actually tells you about all the cells, not just the single layer that we're also focused on, but the cells around it, particularly the fibroblasts, which are proliferating. And I just have never seen any of you all or any of your colleagues do the study I talked about. And I know it's hard to image the pancreas. And so better, finer ways of seeing things. And the absence of that tissue that Professor Allen likes to analyze through the RNA-seq machine potentially would be revealing on a simple level. And that's actually what I was teasing you about, about considering some non-invasive ways to ask about the health of the pancreas, because then you can, talk about the tissue surrounding the pre-neoplasm, et cetera.
Yeah, I mean, I agree. And I also agree with Liz's comment. Also, I think there are a number of ways to think about this. One of the ways we've been thinking about it more recently is, as you just mentioned, as sort of like a pancreatic health approach. We're trying to understand that there are a lot of impacts of these lesions on the normal pancreas function. And can we devise sensitive tests that define that in a way that's also specific enough? Right? If pannins are really all over the pancreas, we have to be careful that if we find very sensitive markers of dysfunction, that we're not just picking up lesions that will never become cancer. But I very much agree. And I think that expanded view of proliferation, knowing that there are cells in this environment, not just as you said, not just the epithelial cells, but the surrounding cells that are there that are also proliferating. That concept, I think, is a really interesting one. And to Liz's point, I think we need to be considering all the cells that are recruited that may lead to whether it's an imaging distortion that we can see, that the AI picks up that our eye can't see, or there's some biology there that we can then intervene upon with, you know, Peter's approach, where we say, here's the biology of what's happening as these cells are recruited. How do you intervene as interception? I think that's a huge area we should be focusing on.
Okay, so Professor Van der Eijden has a question.
Thanks, Dave. My question has to do with interception and whether, just to emphasize the point that I'm not sure how far surgery is going to get us in a situation where surgery can be so challenging for its outcomes, as you said, compared to other cancer surgeries, and also prophylactic surgery, you know, completely different situation than mastectomy or oophorectomy. So I had two questions. Why have only 75 individuals signed up for the trial? And what have we learned about our efforts to engage individuals in interception? And on the other spectrum, how good do you think the KPC model could be? You know, it's filled with Panin at 4 months. How good would that model be as a test for medical interception approaches?
Well, yeah, the 75 patients, we're not meeting our accrual. And it's about risk. It's about how many patients are at real risk. As we know, you know, the clinics are filled with patients with IPMN. They don't have, the vast majority of them don't have significant risk. So to set the statistics right, where we think that interception may play a role, we need patients who have significant risk. I think we found the group of patients. There are also exclusionary criteria to put someone on aspirin. And actually, unlike in New York City, in North Carolina, there are a lot of sick people. And so we actually have a lot of, we have to exclude a lot of patients because of kidney function and so forth. So I think we've found the right group of patients, because a percentage of these patients are progressing as we defined it. But we need more centers, we need more time. And I think we will still learn a great deal from this. I mean, this is randomized, it's blinded, and I think we have some interesting secondary endpoints where we'll learn if there's any type of hit in terms of inflammation. But it was a struggle in terms of number of patients.
I'm just going to add to this. I think interception is incredibly important, and it's unbelievably exciting. Of all the different things that we've spoken about today, I think it's one of the most exciting areas. And what we need is, we need for all of us to come together and to support these types of trials and to enroll our patients in them. I think that's very important.
So Bob also had a question for you, Peter. Are you wasting your
Or
time?
you can answer it, Dave.
Are you wasting your time with the mice? Or are the mice helping you?
I'll defer to someone who works with mice.
How about Dave Tuvison?
Yeah. No, so I don't think we're wasting our time with mice. So this morning I had a different stage in this great city, sitting next to Jim Allison. And it was a group of people who were trying to shake them down for what's the new ideas in the immune therapy landscape so they can start their companies, et cetera. And somebody asked, are the preclinical studies really helpful, or are they misleading? And he didn't actually answer the question. And he told me afterwards, he said, if I answered this question, there'd be so many disappointed people out there. And he said to me, the preclinical studies are great, but when you give a great drug to a bad doctor, you have a bad drug. And what he meant by that is that the way we design a lot of our studies in oncology, in the field Bob and I spend our time in, and Brian, we don't give the idea a chance to be tested. We don't get the tissue. We don't understand the mechanisms as the trial is going on. We get misled oftentimes. We see home runs. That's what we see by the way we do our clinical trials. And so to Bob's question about preclinical trials, are the mice going to be useful? Well, I don't have evidence that they're not going to be useful. And we haven't, in our own lab, we haven't spent enough time really in the pre-cancer space. But the exciting stuff I see coming out with, Peter said he didn't have sexy drugs. Well, there are some better drugs now, and there are some great immune therapy approaches. and cell-based approaches, things look pretty good. Are there going to be better models? Of course, as we move along. But I personally haven't seen being misled as a major issue. But I'm going to kick it back to you because you have an improved mouse hospital at the University of Pennsylvania. And you've been doing some studies with one of the sexier drugs. And so what do you find and what's your excitement and your reservations?
Oh, I'm supposed to answer my own question? Well, some of these people out here are going to review R01s. And so I would say the KPC model is an awesome model. It's a 1 model. No, it just strikes us that we're in the therapeutic bent. Jim Allison, go back late 90s, he implanted tumor cells and gave CTLA-4 and they went away. And, that's a good preclinical model. And that's how our models are. But to go into interception where we're actually treating not cancer, but, pannins in this case, that's not how we usually do it. Those are tricky experiments for a postdoc. You can't just squirt a bunch of cells into a mouse and start. So these genetic models with bona fide precursor lesions, to me, is a golden opportunity. And so, yeah, we're putting, the formulary through to see. We have to come up with a high throughput assay to know. It's what Brian was saying. These are needles in a haystack, and you're watching a few needles go away. So the operating characteristics of the assay is going to have to change compared to calibers or ultrasound changes. So anyway, so that's the answer. That's how we're thinking about it. I just was wondering if you think we're crazy.
So, 8, 9 years ago now was when we were hatching a chemo prevention trial at the NIH chemo prevention group. And, we went to the what mouse models were available. None of them were, genomically like human IPMN. Some created lesions like IPMN in the mouse model. But when we looked at the mouse models, whatever you gave the mouse model, it prevented their time to progression to an invasive cancer in terms of the anti-inflammatory agents. So it wasn't particularly helpful at the time. We've gone, I am a rank amateur in this space. So we've gone to some of the mouse folks at Duke to create something that has more genomic representation to human IPMN in a different type of model, and we're hopeful that it will be helpful. But I was surprised when we looked at the data 8, 9 years ago that it wasn't particularly helpful.
So again, Bob and I didn't practice that. So you heard the honest response from him. One thing I wish the field did more of is actually study the animals to get the high-grade pre-neoplasms. We haven't, just because you can only do so many things. But we found that when we use transposons in the background of the mouse model, we get high-grade pannin. And of course, the excitement is figure out what the gene is that caused the high-grade pannin, not how do I make it go away. And so for those of you still looking for a project, I know there's a few out there, there's ways to move this forward. All right, so we're at the 20-minute time frame. I pretty much pushed the committee around here. We had a little bit of investment from the audience. We're now going to segue into the rest of the program. Linda is going to make an introduction. After that speaker, we're going to get a break. At the break, ask these brilliant 4 individuals your hard questions that you didn't want everyone to hear. And then we'll come back for the next session. So thanks a lot for this panel. Thank you. It's great. Really great. Really great.
So that was terrific. Thank you all. You can see the passion of the speakers and their desire to really shift the paradigm of this disease. So we're not actually treating disease, that we're getting to the disease before it really impacts individuals, and we lose so many patients. So very exciting, and we're going to hear more in the next session. But first, I'm really excited to introduce Dave Mullarkey. Dave is the Chief Executive Officer of Clearnote Health, which is a commercial stage cancer detection company focused on identifying the deadliest cancers. I've met Dave a couple times, and I'm really impressed with David and with the people he has working at Clearnote, and they have some very exciting products that they're hoping to bring to market. I know that they're working with a couple of people here today, or a couple institutions who are here. So please listen and hear what Dave Mullarkey has to say. Thank you very much.
Thank you very much, Linda, and I'm thrilled to be here today. Just imagine a world cancer-free. Our fundamental belief is that early detection is a starting point for that, primarily to open up more avenues for new treatments to come in. So at Clearnote Health, our vision is, in fact, to try to cure the world's deadliest cancers, primarily through early detection. And the first cancer that we're focused in, where there are millions walking around at high risk for, is the pancreatic cancer, where we're here today. We have an FDA breakthrough device designation for early pancreatic cancer detection using our molecular diagnostic test in one of the high risk groups, those that are newly diagnosed with type 2 diabetes over age 50. It's been shared earlier, probably the most significant difference in survival of early detection versus late is seen in pancreatic cancer. And here's one of the published numbers: 80% survival with stage 1 detection. So Clearnote Health is based in San Diego. We're a private venture-backed company that's been in development for 6 years and have just launched our first commercial test that is now being prescribed by physicians all over the country. So let me just talk a little bit about the technology and kind of how we do this. So our primary analyte is a blood tube. So we're taking a simple standard blood draw, and we're looking at circulating cell-free DNA in your blood. So this is basically circulating tumor cells that have died, shed their contents, and are floating in the blood. That's the primary focus. Within that, was brought up earlier, our particular biomarker is focused in the methylation pathway. And the methylation is a chemical process involved with turning genes on and off. And these methylation signals across your entire genome, put together through pretty sophisticated algorithms, give you a sense as to whether or not cells are about to become cancerous. So this is very, very important at the early stages of cancer formation. And 5-hydroxymethylcytosine, 5-HMC, as you see up here, is the stable epigenetic biomarker that we measure. And we have, that's a core part of our assay. We include some other information to help improve our performance, but this is a standard, well-known pathway and one that we've developed and tested and validated an assay to be used here. So the way the test works, as I said, it's a standard blood draw. You send it to us in the lab. Usually we collect 2 tubes in case there's something wrong with one, just in a little standard kit, just gets shipped to us. And then we extract the DNA and we run our 5-HMC assay, but we also include some other information, some genomic information into the algorithm, particularly copy number variants and the fragment size of the cell-free DNA. Those combined with, after tremendous development in machine learning, have created a classifier of whether cancer signal is detected or not. And that's the primary output that we have, is a patient report of whether a cancer signal was detected. And typically, obviously, you'd move towards imaging or some other confirmatory approach to address that. So Avantect is the name of our test. Avantect.com, for example, this is a little snapshot of that. The test is commercially available in the United States, and we got our CPT code recently and also got priced by CMS recently. So it is available, and we're just kind of ramping up the efforts to build awareness and expand availability of this test over time. Let's talk about a recent case study. This just came to us just a few weeks ago, in a situation where there's a 77-year-old woman who did have an ATM variant about 8 years ago and was being monitored in a high-risk genetic clinic. She entered a clinical study using a multi-cancer test earlier in the year. And unfortunately, she got a positive, but the follow, and it was pointing in the direction of breast and colon cancer, but imaging and follow-up was negative. Part of the trial, she came back 6 months later, pancreatic cancer was detected at this time. And in fact, the mass was identified after that. This particular physician was part of our physician experience program, which is kind of an early access program for, and wanted to do the Avantec test immediately, because the Avantec test was developed and validated for pancreatic cancer. So this isn't a test being used across 10, 20, 50 cancers. It's very specific to this particular disease. And in fact, positive signal was detected. There was a biopsy, and in fact, stage 3 pancreas cancer was diagnosed, and unfortunately too late for surgery, but treatment is ongoing. So a question becomes, and we've been asking for, is there a way, a little easier way, a little more accessible way to actually surveil these particular patients? And what you're seeing here is if this test was potentially used earlier on when that patient was identified as being at higher genetic risk, could in fact we detect this pancreas cancer before stage 3, which unfortunately was the case for her. Our belief initially for diagnostic tests, and I was presented earlier about trying to get the positive predictive value as high as possible. So how do you have the patients that you're offering a test to have the highest potential prevalence of that particular disease? And in fact, that is enriching that group, trying to focus in on the higher risk groups. So yes, we're familial and genetic, but also those with the new onset diabetes over the age of 50, chronic pancreatitis. This is kind of where we're starting in that group, but the test detects these signals whether you're part of the high risk group or not. It's just that it's obviously much, much less common in the average population. So, it doesn't make sense to offer it too broadly to start, perhaps down the road, but right now focus on those at the highest risk for it. So how does the test work? This is our pivotal validation manuscript. This is the 4th study as part of the development process for our test. And this was published in a peer-reviewed journal recently. And what's most significant in this study in over 2,100 patients is really that second blue bar. Is how do we perform at early stage detection, stage 1 and stage 2? And right now, there are not a lot of molecular, or there's not, the number of tools available for early detection are quite limited. So this is a great starting point. As we get more samples and we continue to optimize our algorithm, things are only going to improve. And what's also important is the very low false alarm rate or false positive rate, which in this particular case is about 3%. So really encouraging early views that also within this patient population, it was a bunch of different groups. It was patients with long-standing diabetes, new onset diabetes, and other risk factors. So it's a nice rich set. Also, there was a lot of discussion earlier around cysts. And this is a smaller study, but it's one that shows that the power of detecting this signal in particular cysts, and this was part of a validation manuscript that is published. And this is our ability to detect those with high-grade dysplasia, moderate or high-grade, versus the benign or low-grade. And you see very significant separation. This is 88% detection rate for those with moderate or high-grade dysplasia, again, at about a 98% specificity or 2% false positive rate. So we have some ongoing studies right now expanding the cohorts. These are primarily IPMNs. And we'll continue to build on this and do a final pivotal validation. but it's very encouraging that this early stage of where cells are potentially starting to become cancerous is being detected with this easy to use blood test. And just, I know we're here to discuss pancreas cancer, but this concept of high mortality cancers that are typically detected at late stages where the early detection tools are limited also plays out in ovarian cancer. And this is data we presented recently, or not very recently, but we're actually doing the final pivotal validation on the next 2 months here. But it shows a trend here of very strong early stage performance and across with very high specificity. So it's encouraging. And there are many of those with genetic predisposition or familial or the high risk individuals that, many of the females could also be in the situation where ovarian cancer could be a concern too. So this is an encouraging thing. So just to wrap up, where we see the future for early detection, particularly of pancreatic cancer, is striving for a world free of cancer, focused on detecting those cancers early in patients at the highest risk as a place to start. And this is greatly going to enhance the effectiveness of current and then new treatments on the way to extend life. And we're already aware that there are many therapeutic companies looking at studying the use of their drugs, not in late stage where they already are, but decreasing the dosing frequency, decreasing the dose in early stage. The issue is there haven't been enough of those patients for them to study in the past. That's going to change now with more routine or expanded use of our test, and it's going to really proliferate the number of treatment options overall. So I urge you, there are other companies in our field that are moving forward with different technologies. They're at different stages, different approaches. There's multi-cancer, there's single cancer. Our test was built for pancreas cancer, and it's available today, and there are other tests available today. So I encourage you, if there is any interest in understanding how it could be utilized within your practice or perhaps part of a study that you have ongoing, please feel free to grab me. I'll be around this afternoon, and really look forward to working with the foundation in years ahead. And thank you again, Linda, for the opportunity.
Okay, welcome back, everybody. And so we're going to segue into the therapy part of our meeting. And for that, we're going to have a proper therapist. And so Dr. Elizabeth Jaffe is going to chair this part of the meeting. I met Liz more than 25 years ago, so probably 30 years ago, maybe more than that, 35 years ago, perhaps. I was very young. And she was starting her postdoc with Drew Pardoe, and I was doing my PhD with Doug Fearon, who I saw in the audience before. I don't know if he's come back. Who's a terrific immunologist. And I asked Liz what she was going to work on. She said she was thinking about pancreatic cancer. I said, I don't know anyone who works on pancreatic cancer. She said, me neither. But she started out, learning as an immunologist and sticking with immunology back when it was not popular and we didn't know nearly as much. There was something called suppressor T cells, for those of you, again, who went to medical school that many years ago. We now have different names for these things. And she really, has transformed the field of immune therapy and pancreas cancer. So we were really lucky to recruit her to the Lustgarten to serve as our chief medical advisor. And with her abilities, she was able to start a clinical translational part of our organization, and we now have 9 trials going. So for her day job, she's the deputy director at the Hopkins Sidney Kimmel Cancer Center, and she co-directs the Skip Virag Pancreas Cancer Center. She's also the associate director at the Bloomberg Kimmel Institute. Outside of Baltimore, she plays a big role nationally. She was the president of AACR. And she served on she serves at the National Cancer Institute at a very high level as a senior advisor to the NIH, as well as to President Biden when he was the vice president as the Moonshot Blue Ribbon panel. But now, I'd say more importantly, on a cancer advisory panel, that she's I think the main voice representing us. And so we're here to, again, honor Liz for all of her achievements and introduce her in such a way that she can talk about therapies with her panel of 3 experts today. So thank you again, Liz, for all that you do, and we look forward to your session.
Thank you, Dave. He's always so kind to me. And I also want to thank the Lustgarten Foundation because they have done so much for this field. As Dave said, we were in this very early, and I've been in it for a long time when others weren't. And I have to say that without the Lustgarten Foundation, we wouldn't have made the progress or see as many people at a meeting like this without them. So very thankful. I also, the Lustgarten Foundation has a very important place in my heart. So I did know Mark, and I think Andy, his son is here, knows that I knew Mark. I knew Mark 26 years ago, before the Lustgarten Foundation. And Mark, of course, was treated in New York for his metastatic pancreatic cancer. And at that time, as Dave said, there really wasn't a lot going on. I had just opened up my first clinical trial, and it was an immunotherapy trial. And I got a call from Mark, and he had looked everywhere for something. And there were phase 1 studies. That's good, new drugs. But in those days, we couldn't tell patients that our phase 1 drugs were going to work. They weren't targeted therapy. They weren't precision medicine. They were just drugs that typically were taken from other cancers that were having some activity in other cancers and being applied to cancers like pancreatic cancer, and typically had no response. So Mark was a brilliant man, and he was brilliant in his own field, as we all know. We know everything he had done, but he was also very informed about pancreatic cancer and biology of pancreatic cancer. And he came to visit me to talk more about our vaccine. And he really liked the concept of activating the immune response. And it was a really early concept. We didn't know any of the targets in pancreatic cancer. So I took a whole tumor cell, pancreatic tumor cell, and hoped that there were antigens in there, which there were, it turns out, that could activate an immune response. And he asked a lot of hard questions. And one of the questions was, why isn't there more going on in this field? Why am I looking for something and there's nobody who has anything that's going to help my cancer? So I mention this because I wish he was here today. I know Andy, of course, wishes he was here today. You know, he became a friend. I lost him too soon, of course, as others who really liked him lost him. We had some amazing discussions. But he said, you know, what would happen if you had all the money in the world to fight pancreatic cancer? And his family and friends started the Lustgarten Foundation. And 25 years later, we have all of these new therapies, all of this new science, biology. And as Dave had alluded to, we're really at a tipping point for this disease, because we have all this biology. We know a lot of the targets, not all of them yet, but we know a lot of the targets or a lot of the proteins and signals in these cancer cells that we're able to start to develop drugs that are pancreatic cancer specific. This is very important. They're not drugs that are going to work on breast cancer or melanoma. These are drugs that are targeted to pancreatic cancer. And there are some really good examples. In addition to the fact that now we could offer patients with metastatic disease 2 types of chemotherapy, some of which we do understand what they're targeting in the pancreatic cancer. We have the PARP inhibitors for a subset of patients who have DNA repair deficiencies. We have immunotherapy that works in patients with a high mutational load. And certainly we're all very excited about the new KRAS targeted agents. So again, we're not done. We have a lot to do. All of you have to help us do it. But the Lustgarten Foundation has been there with us for 25 years, and they've gotten us to the point where you're going to hear today from an amazing group of panelists who are speaking about all the advances that they have been able to do, and also to give us hope that there are new therapies that are on the way. So as you could see, we have 3 wonderful scientists who are going to talk to us about the work they are doing that's impacting patients. The first will be Dr. Zhen Ye. And Dr. Zhen Ye is a surgeon researcher, and she's from UNC at Chapel Hill. And she's been studying targeted therapies, and I think she's going to talk to us today about some new targets that she's identified. Welcome, Jen. Jen.
Thank you so much, Liz. It really is an honor to be here to help celebrate the 25 years of Lustgarten's commitment to really improving care for pancreatic cancer patients. I thought I was told that I had to present something new, so I will try and do that in 15 minutes. For those of you who've heard me talk, I usually talk about tumor subtypes and their impact in patients. And I will talk a little bit about that. That will be my disclosure. We will be talking about the pure subtypes that we first identified. And this graph really reminds me to talk a little bit about what Dr. Jaffe just said, which is that we actually, in the last 10 years, we have a lot more treatment options. Yes, we have a long ways to go, but this group of treatment options now really behooves us to start thinking about how can we select the treatment that actually will benefit the patients the best first line. And I think this will go into sort of the bad drug, or good drug, bad doctors, or good drug, bad clinical trials. I'll mention that later on. But just to, this is some background data. As many of you know, we embarked on actually what the intent was to try and identify compartment-specific signals in pancreatic cancer a while ago. And that's how we ended up with finding 2 tumor subtypes that we called basal-like and classical. We've been reassured when looking at contemporary data sets that these tumor subtypes still are very clinically impactful. Their clinical implications have stayed over the years. And what has been most intriguing to us and also troublesome is the fact that the orange or basal-like patients tend to be resistant to at least FOLFIRINOX-based therapies. And therefore, the how and the why of why these patients are not responding has been something that we've really tried to focus on. To help answer this question of are basal patients more responsive to other therapies than FOLFIRINOX, we partnered with our molecular pathology group at UNC, developed a laboratory developed test that's now CLIA approved, that's now in clinical trials, that's with the lead institution being MCW, where patients are getting US biopsies, paraffin embedded, sent to UNC Health for the nanostring subtyping assay. The results come back in less than 5 business days. They've enrolled about mid-20 number of patients now, and based on the subtyping results, patients are being selected for first-line therapy.
Thanks so much, Jen. That was terrific. So I think what you're seeing is that after 25 years of investment, we're able to actually start to dissect out in human tumors in association with clinical trials, the mechanisms by which some of these treatments are working, but also to understand the biology. And clearly we're learning a lot, and Jen explained to us some of the challenges in understanding the role of cancer-associated fibroblasts and tumors. Now, I think the other interesting aspect is that with this investment in biology, we also had another major advance, and that was in technology. And it's only been since about 7 or 8 years ago that we've really had the technologies that can dissect a small piece of biopsy tissue and really start to understand every DNA change, every protein change at a single cell level, and even start with computational approaches to look at interactions between those signals. So I think you're going to hear next from Dr. Jennifer Knox, who has been running a multi-center and also multinational Canada and the US clinical trial looking at the two different chemotherapies as first-line chemotherapy for patients with pancreatic cancer. But what's most important is what she's really been doing is making sure that we are dissecting at every level, genetics, tumor microenvironment, all sorts of levels, including developing organoids to try to understand sensitivities in tumors. So we're going to hear from Jennifer the progress on this trial, which is called the PASS trial. Thank you, Jennifer.
Here we are. Okay. Thank you so much to Lustgarten for this incredibly nice invitation. I'm very flattered to be amongst this crowd. I appreciate the support. So everyone talks about moving the needle with precision medicine, and I think boldly I'd like to say it's time to accelerate the movement of that needle. We might be ready for that. My disclosures. So we've talked a little bit about this, but we know that pancreas cancer, while there's been improvements over the decades, it is still strongly an outlier with every other cancer. And we have to be honest, it does diagnose late. Patients deteriorate very rapidly. Many patients do not get a chance to be treated. Despite progress, our treatments to date are fairly ineffective. And we've talked about this clinical spectrum where, unfortunately, the vast majority of patients are diagnosed with advanced or incurable cancer. We want to move these numbers, shift everything to the left, and I'm a big fan of all that research that's going on. Currently, I work in the incurable and advanced stage, and I'm going to talk about that mostly today. Now, I just want to, if you look at the progress that we've made in drug therapy over the last 25 years, and the positive trials are in the color, the red color, you can see things started to get better, first with FOLFIRINOX and then gem/nab-paclitaxel, where we had new standards of care, gemabraxane in a slightly frailer population. But then, although the HALO trial was negative, look how well gemabraxane does when it takes 2 more weeks to get a patient enrolled on a trial. PA7 was adding immunotherapy, negative. And then this year we had NAPOLI-3, which is liposomal irinotecan being added into the FOLFIRINOX regimen. A little more GI toxicity, quite a bit more cost. And I am one of the critics. It isn't really moving that needle above that 12-month survival. And then we recently, just last month at ESMO, saw this Japanese trial. We have to unpack this a bit more, in where first-line treatments of gem/nab-paclitaxel seem superior to the platinum-based ones. But we're yet to see what the breakdown of the HRD cases in some of these trials are. I think my point of showing all of this is I don't really think that strongly that one is better than the other. I think that these regimens can be very helpful for some patients, and I think they can be very unhelpful and very toxic to other patients. And time has come with these signatures and that where we have to pick the right one for that patient because they don't have a lot of time to waste. So yeah, my group a few years ago started this COMPASS trial at a time we were a bit disillusioned with industry trials and things, and we wanted to do a deep dive into the genomics of metastatic disease, because at the time what was known was mainly in resected series, and we wanted to make it very feasible. And so, the laser capture microdissection was sort of that innovation that helped us to get a genome read on every patient that came through the door that was well enough to have chemotherapy. And that's because we could enrich for this low cellularity that is common in pancreas cancer. And so you get a more realistic denominator of the population you're actually studying. And that matters because you see new things on the DNA that you would otherwise miss. So we've done COMPASS for some time now. And here's sort of a bird's eye view look of the 300 genomes on the OncoPrint. Now there's a lot of information here and there's some heterogeneity. But what we've done is you can see it's the big group is HR proficient. And over here we have the deficient, which is a smaller subset, although we can treat them better with platinum and PARP inhibitors. And then there's this intermediate group, tandem duplicator phenotypes, which I'll talk about in a bit. But anyway, a lot of information. How do you bring it into the clinic and use it? Clinicians need simple pathways to make decisions quickly for patients. And as Jen also mentioned as well, we noticed very early on, well before 300, maybe in the first 75 patients, that there seemed to be a strong predictive value of basal classical. Basals all seem to progress on chemotherapy, and the classicals were the ones that were doing a little bit better. And you can see whether they got, if they got FOLFIRINOX, they did a lot worse. One could argue that's harmful. And if they got gemabraxane, it was more middling. Now, it wasn't a randomized trial, but still. So the basals are very different, more inflamed and more hypoxic. And there's different ways to recognize them today. We were looking at the GATA-6 as a way you could just look at a slide and call the patient. But what we're hoping for, just as Dr. Ye was saying, is they should be treated differently. They should not be getting standard chemotherapy that doesn't work. Now, nuclear transporter hint, you know, I've been hearing about it since I was a grad student. It's never really come into the clinic. And here what we did is we looked at patients on gem-nab-paclitaxel that were hint high, much more likely to live longer than if they were hint low, but no difference if on FOLFIRINOX. So very simply, hint is a biomarker for gem-based therapy that could be used. We spent a lot of time looking at whole genome classifiers, and the HRD detect is very helpful because it picks up an additional 7% of cases that you would miss if you just looked at germline. And although 7% doesn't sound like a lot, these patients really do benefit if you know who they are and have them on a platinum and a PARP maintenance and that. And there's more and more data sets that have come out suggesting this isn't just a modest improvement. This could be almost a year of additional survival with the right chemotherapy. So you don't want to miss those. The tandem duplicator phenotype, I'm just showing you here, don't really have a good explanation for what it is, other than that they're the green ones and they cluster on the better side of the waterfall plot, responding better to FOLFIRINOX chemotherapy, but they're different from the DDR HRD cases. So, you know, if you knew that, it might influence your care. And I've had a couple of patients in my practice where knowing that has actually led to switching and them doing much better. We teamed up with Dave Tuveson's lab a few years ago while he was trying to develop the patient-derived organoids in pancreas cancer to try to recapitulate their signature subtypes and see if these models, which you can grow much faster than PDXs, could actually be something that could come into patient care, depending on drug sensitivity in that. And so we thought that was also a good idea to take forward into a trial. And I'm just going to end on COMPASS by saying we have a big data set. We have shared it now with over 100 international institutions. And so I'm optimistic that a lot more is going to be discovered from that set. So with all the disappointing trials, we want new ideas and new platforms for pancreas cancer. In the PASS-1 trial, which Liz and I co-run, we wanted to really look at a smaller trial, randomized, but really test multi-omics and see if we could prove some of these biomarker hypotheses in real time for patients. So here's the schema. It's quite simple. These are de novo metastatic patients that are not HRD, and they're randomized 1-to-1 to the two standards of care, and they get treated to primary endpoint. We have a number of secondary and exploratory. But what is key is they get those big biopsies right off the front from the tumor and the blood so that we can put them through the multi-omic pathways and try to read those out in real time. And you can see we have some very high-powered collaborators on this study brought in because each one of these institutions carries a real expertise and ability to sort of take the scientific question a little further than one group could do. So for example, Liz at Johns Hopkins, you know, would be real experts at looking at immunophenotyping. We also have the opportunity to give junior investigators some leadership on a very complicated trial. So Rob Grant is looking at the machine learning collaborations on multi-omics. Amber Habowski, who I think is in the audience, a young investigator who's really leading this high throughput PDO screen in Dave's lab, you know, trying to grow every patient's PDO, characterizing them, testing them, and then giving a readout that may or may not recapitulate the patient's result. And it's interesting, sometimes the genomics points out other drugs that would be more interesting than the standard chemotherapy, and we go back and study those pathways as well. colleagues at Dana-Farber, Andy Aguirre and Harsh Singh are now leading the circulating tumor DNA question. There's so many important questions here, but we have these lovely serial specimens to look at. And so perhaps that dynamic monitoring to be more fast and innovative on treatment is really key, and I can't wait to see this. Now, this is our molecular tumor board run by young investigator Grania O'Kane, where basically every patient's case at the 8-week mark have their CT scan, their clinical history, DNA, RNA, PDO, lip search. Where do they fit into our database? What does somebody else know? And we try to put together a recommendation for second-line therapy that is precision based and would help the patients. So I'm absolutely delighted to say we're down to the last maybe handful of patients to accrue. So these abstracts will be coming out in the next months. And hopefully we've been able to show some predictive value to some of these biomarkers. Do they lead to clinical decisions? And then can we bring them forward into the first line setting, which we hope will become a PAS-2 trial. And I just keep an eye on this. This is ongoing in PAS. But you can see of the patients that get to go on to a second line therapy, and it's just a bit sobering that at the best of times, that's about 60%. So that's why we have to make the first line better. But of that 60%, about 64% go on to a correlate driven, either genomically or PDO. And I think we'll have to see how that pans out for survival. But, 3-4 years ago, we were maybe getting 10 to 15% at best with a precision medicine. So I hope that is exciting and real. A lot of new therapies on the horizon, and you can't talk about pancreas without thinking about the potential for the KRAS drugs, and there's lots of them, and they're under study. And just last month at ESMO, we saw this first in human Revolution Medicine, where just about every patient is getting some shrinkage, and this is targeting G12D, V, R, and S, and some of these are quite durable. I mean, you don't see that in pancreas very often, and it is exciting. Imagine bringing them into the front line, bringing them in combination with IO or chemotherapy. Lots of new ideas for DDR and PARP inhibitors and combinations underway. This is very exciting study by Kim Reese, because it shows that if you put a PARP inhibitor with a CTLA-4, you get a very meaningful maintenance control period, which is non-cytotoxic drug, not chosen on any genomic finding, just chosen on the fact that these are the patients that respond to platinum. So that really broadens that bucket for more benefit for patients. Everyone's talking about Claudin, MDM2, MTAP. These all seem to be quite legitimate targets these days, and the studies are underway. And so we're going to have more options in higher percentages than we've ever had before. So I'm going to wrap up here by saying that, if you're doing your job well and you're doing somatic and germline testing and you're thinking about things, you can bucket patients into much better than standard of care in these different buckets for about maybe 30% of patients. So really, what are you going to do for the other 70%? And this is where I think we should plan these trials now. We were talking about it earlier with upfront selection, enrichment very quickly for early responses, using whatever diagnostic tools and classifiers we think are legitimate now and we can act on quickly, and then optimize the response for every patient. So reflex testing, take that KRAS bucket and make it very broad, perhaps expose every patient to it, and maybe in combinations or as maintenance. Broaden the definition of DDR, platinum responsive, HRD detect, TDP, all those different things to make that bucket wider. Someone's going to turn cold tumors hot. It might be Liz, might be not going to be me. But when that happens, that's going to synergize with these other treatments like the KRAS inhibitors. And then chemo, I think chemo is going to be around for quite some time as a platform for many of our treatments across neoadjuvant, adjuvant, and early stage. So if we're going to give chemo, let's give chemo that's more likely to work and has less toxicity. And so the signatures are going to be very important. And I really do think, especially from PAS-1's data, we're going to learn how to and where and how to integrate circulating tumor DNA so we can be smarter in our switches and our decision-making over time. So on that note, I'd like to end. Takes a village. I work in a very nice one, And I just want to point out some of my key collaborators over the year, Steve Gallinger and Fayez Nada, Grania O'Kane, and there's Dave, and there's Brian, you're there somewhere. And Liz is there, and a credible team. And I couldn't do it without all the support, and especially for past one for the Lustgarten Foundation. Thank you so much.
So we're really at a special time. We're really moving from generalized chemotherapy to pancreatic cancer targeted therapy. And I think this is important because we're finally understanding what it is in pancreatic cancers that are the vulnerabilities that we can target. And speaking of turning tumors from cold to hot, our next speaker will talk about a new way of trying to vaccinate against pancreatic cancer now that we're able to determine what the genes are that are altered, not just in pancreatic cancer, but what's really exciting is this has gone from pancreatic cancer to patient-specific vaccines. So I'm very excited to introduce to you Dr. Vinod Balachandran, and he's at Memorial Sloan Kettering, and he's going to talk to us today about his vaccine work. Welcome.
Thank you very much to the Lustgarten Foundation for the opportunity to really be here. It's a true honor, and also congratulations for 25 years of being at the vanguard of pancreatic cancer research and clinical application. Really quite remarkable. Today, I'd like to highlight a story that I thought was especially meaningful because essentially all aspects of this story were made possible through funding by the Lustgarten Foundation. Funding an idea which at the time might have been considered a bit high risk idea, but this is really, I think, what is needed to make progress in this field. So pancreatic ductal adenocarcinoma, or PDAC, thought to be the model immunologically cold tumor that we think of as cold rather from the antigenic sense, as PDACs have few mutations and thus fewer mutation-derived neoantigens that we now think of as a dominant class of rejection antigens in human cancer. And this being one of the reasons why PDACs have fewer T cells, rendering them largely resistant to immune checkpoint inhibitors, and more broadly typifying the nearly 80% of cancers that are similarly lowly mutated cold and thus immunotherapy resistant. But fascinatingly, although most are cold, a rare 9% or so are in fact quite hot, with primary tumors that are enriched in approximately 12 times greater densities of activated CD8 T cells that we believe target mutation-derived neoantigens. Now, these tumors are also enriched in other immune cells that amplify these antigen-specific CD8 T cell responses. So for the past several years, we've been studying these patients with really two questions in mind. How do they do this, and how might we replicate this? Specifically focused on identifying these mutation-derived neoantigens, which we believe are the targets of these CD8 T cells, and more recently, efforts to deliver these mutation-derived neoantigens to patients using mRNA vaccines. Now, what we know about these mutation-derived neoantigens across cancers is that these neoantigens mostly arise in non-synonymous mutations, of which most of them are single amino acid substitutions, largely in passenger mutations. So we also know that less than 10% of these neoantigens are in fact immunogenic, and there appears to be immunodominance in tumors. So to vaccinate against a hypothetical tumor where a more immunogenic orange neoantigen spontaneously activates orange T cells, yet also harbors these less immunogenic variants, you could envision a variety of scenarios ranging from vaccinating against the yellow target and doing nothing, the blue target and making new T cells, the orange target and amplifying pre-existing T cells, or perhaps ideally vaccinating against both blue and orange targets to both prime new T cells and amplify pre-existing T cells. Now, all of which requires a strategy to both do two things: select the immunogenic fraction and estimate this dominance, for which we, supported by the Lustgarten, have been working on a quality model to estimate the dominance hierarchy of immunogenic neoantigens, thus allow for rational selection of neoantigens that would be suited for clinical application. And in this model, we estimate a neoantigen to be more or less immunogenic based on features of non-selfness and selfness. And we estimate neoantigen non-selfness based upon neopeptide sequence similarity to other known antigenic peptide sequences derived from infectious disease epitopes. And we estimate a selfness based upon how these single amino acid substitutions differentially bind either the MHC or the TCR with respect to the corresponding wild type amino acid that we estimate based upon the amino acid substituted position as well as a residue. And what we found with this quality model was that in a lowly mutated PDAC, and in highly mutated cancers such as melanoma and a lung cancer, tumors that were enriched in high quality but not a quantity neoantigens identified patients with a longer survival. So introducing neoantigen quality as potentially a metric of tumor neoantigenicity, and also introducing the idea that perhaps these lowly mutated tumors like a PDAC might in fact harbor neoantigens that are both clinically relevant and potentially therapeutically targetable. Now, this was further bolstered by the observation that we could also see neoantigen, high-quality neoantigen specific T cells that were found in archival tumors of these rare long-term survivors of pancreatic cancer with identical high-quality neoantigen specific T cell clones persisting spontaneously in the bloodstream for over a decade, suggesting perhaps that these high-quality neoantigens could stimulate long-term immunological memory and thus perhaps were suited as antigens for vaccines. Now, of course, this was phenomenological because we did not have a control group here. So we wanted to see, well, can we now build further evidence that these high-quality neoantigens are in fact bona fide endogenous antigens in PDAC? So to answer this, we did a follow-up study here where we examined how these high-quality neoantigen-enriched primary tumors in long-term survivors evolved out to 22 recurrent tumors over a 10-year time frame, and compared to a control group, what we found was that although these tumors had a longer time to evolve, they paradoxically evolved recurrent tumors that had less mutations and less neoantigens compared to these short-term survivors. They evolved recurrent tumors that had overall less immunogenic substitutions and overall evolved recurrent tumors which had less neoantigenic recurrent tumors. So suggesting that these high-quality neoantigens were under bona fide immune selective pressure and thus perhaps were bona fide endogenous T cell targets in PDAC. So our interpretation based upon these findings was that in these long-term PDAC survivors, they spontaneously develop these high-quality neoantigens that stimulate neoantigen-specific T cells that may delay PDAC recurrence. But as nearly all PDACs harbored neoantigens of varying immunogenicity, this raised the question whether neoantigen immunity could be therapeutically induced when it is not spontaneously immunogenic, as in the case of these long-term survivors. Now, you might say, why individualized and why mRNA? Well, the rationale here was that these high-quality neoantigens in these long-term survivors, they derived from tumor-specific passenger mutations indicating the need for individualization, which we felt at the time the most flexible technology for rapid custom cancer vaccination in the clinic was to use mRNA. So back in 2017, our group at Sloan forged a collaboration between Genentech and BioNTech to test individualized mRNA neoantigen vaccines in pancreatic cancer. lowly mutated cancer historically thought to not generate mutation-derived neoantigens suited for vaccines. And to test the hypothesis that in the adjuvant setting, these individualized mRNA neoantigen vaccines could expand neoantigen-specific T cells to potentially delay PDAC recurrence. And we wanted to test this in a single center investigator-initiated phase 1 clinical trial where we targeted to accrue 20 surgically resectable PDAC patients on whom we performed surgery to remove their primary tumors in New York. And then within 72 hours, we shipped the tumors to colleagues in Germany who then sequenced the tumors, identify the neoantigens, and custom manufacture individualized mRNA vaccines. These include up to 20 class 1 and class 2 restricted neoantigens delivered as 2 uridine mRNA decatopes in lipoplex nanoparticles intravenously. Now, while this is ongoing, back in New York, at 6 weeks after surgery, we benchmarked patients to receive a single dose of PD-L1 blocking antibody atezolizumab. And at 9 weeks after surgery, the first of 8 consecutive priming doses of custom vaccines, followed by standard of care modified FOLFIRINOX chemotherapy and a vaccine booster. So we treated our first patient on this trial in December of 2019. And as you know, shortly thereafter, we had to contend with running this trial, which was quite complex through the pandemic, which posed several challenges, including clinical research shutdowns, supply chain disruptions, which was important for this trial, which involved a real-time cross-Atlantic transfer of patient material and drug. And of course, BioNTech had the distraction now to also make vaccines to save the world from COVID-19. But despite this, thankfully, due to the continued support by the Lustgarten Foundation and the infrastructure of colleagues and staff at MSK, we were able to not, in fact, slow the trial down, but despite these challenges, in fact, accelerate the trial to complete it, despite the pandemic, a full year ahead of schedule. Now, is rapid custom cancer vaccination feasible? Short answer is yes. You can see here our achieved time to atezolizumab was within 1 day, but more importantly, achieved time to vaccination was within 3 days of benchmark times. So rapid custom cancer vaccination, we believe, is feasible, fully integrated into a standard clinical workflow, and even after complex oncologic surgery, as is required for PDAC. Okay, can individualized mRNA neoantigen vaccines stimulate T cells in PDAC, a lowly mutated tumor historically thought to not contain mutation-derived neoantigens suited for vaccines? So to answer this question, we use 2 tests to examine for vaccine-induced neoantigen-specific T cells, a primary test, which is a standard ex vivo interferon gamma ELISpot, and a confirmatory test to identify vaccine-induced neoantigen-specific T cell clones using TCR-V beta sequencing, an assay that we call CloneTrack. Both assays that preferentially detect high-magnitude vaccine-induced T cell responses. Now, with these 2 assays, what we find is that these individualized mRNA neoantigen vaccines induce T cell responses in 50% of unselected PDAC patients. And we find that these vaccine-induced T cell responses are in fact quite substantial in magnitude, reaching as high as 10% of all peripheral blood T cells, and appear to be durable, lasting as high as 2.5% of all blood T cells, even 2 years later, despite a post-vaccination chemotherapy, and includes T cells that recognize both single neoantigens as well as multiple neoantigens. And when we look at a median follow-up of 18 months, now this extended beyond our pre-specified secondary endpoint of 18-month recurrence-free survival, what we find is that patients who generated an immune response to these individualized mRNA neoantigen vaccines, these responders, they had a median RFS that was not reached compared to patients who received the vaccine but were in fact immunological non-responders, who had a median recurrence-free survival of 13.4 months. And we did further analyses on these two cohorts to confirm that this stratification, given its small sample size, was not in fact due to differences in patient selection or patients with different prognosis. So suggesting perhaps that vaccines may delay PDAC recurrence. Now, what was also interesting is that we were interested to know whether or not this could just represent differences in host fitness. Namely, did patients differences in their immunological fitness as evidenced by their inability to generate an immune response to the experimental vaccine potentially be a confounder in this correlation that we observed. So to answer this question, we examined whether patients who were experimental vaccine non-responders could generate a concurrent immune response to a concurrently administered unrelated mRNA vaccine, which in this case was SARS-CoV-2 vaccination. And what we found here was that these non-responders mounted equivalent humoral and cellular responses to a concurrently administered unrelated mRNA vaccine, SARS-CoV-2 vaccination, so suggesting that differences in host fitness did not confound our observed correlation between experimental vaccine response and delayed PDAC recurrence. Now, looking at potential biomarkers of vaccine response, specifically at neoantigen quality and the key parameters of neoantigen quality, namely tumor clonality and antigen quality, even though our study was not designed and powered to detect differences in these metrics, it was still interesting to observe that in this small data set, these vaccine responders had more clonal tumors. And within these responders, if you ask, well, can neoantigen quality discriminate between neoantigens that either generated an immune response or did not generate an immune response? You can see here, even though the sample size is low, we were able to note that perhaps neoantigen quality could in fact discriminate between immunogenic vaccine neoantigens and non-immunogenic vaccine neoantigens. We think more broadly, this primarily reflects that these sequence-based metrics can be in fact selected a priori, and thus because of that, this vaccine the ability to select and iterate and improve vaccines over time is feasible. So why is the immune response then plateauing at 50%? So I mentioned to you that the experimental vaccine that we used in this clinical trial is intravenous vaccination, and this is designed to maximize a total body-wide lymphoid organ targeting to maximally generate a cellular immune response, T-cell response, in contrast to the intramuscular vaccination strategy for antibody and B-cell responses to pathogens. And one organ that this intravenous vaccination strategy is reliant on to maximally generate an immune response is the spleen. And in preclinical models, splenectomy abrogates the strength of the immune response by about 50%. So as you know, for a PDAC, there are two different types of surgeries that we perform routinely as part of standard of care. One which involves routine removal of the spleen. So it was notable that these non-responders were slightly more enriched in patients who had had their spleens removed at the time of surgery. So these patients did not, in fact, have a spleen when they received vaccination. So we think perhaps this could be one reason why the immune response that we saw in this clinical trial was 50%. So in summary, we think mRNA neoantigen vaccines are an encouraging therapeutic signal in pancreatic cancer, lowly mutated cancer, historically thought to not contain mutation-derived neoantigens suited for vaccines. We think such vaccines are feasible in clinically relevant timeframes and that they can be fully integrated into standard clinical workflows even after complex oncologic surgery, as is required for pancreatic cancer. We think these vaccines are quite immunogenic, both substantially and durably expanding T cells in 50% of unselected PDAC patients, and preliminarily that vaccine-induced immunity correlates with a delayed PDAC recurrence. Now, of course, this is a small single-center phase 1 clinical trial, but we think this is a sufficient evidence now for a future broader testing in pancreatic cancer with a follow-up randomized phase 2 clinical trial that is now currently open and enrolling at Sloan Kettering and is slated to enroll at about 80 global sites targeting around 250 or so patients. And the design of this clinical trial is broadly in the experimental arm, testing a version of the design that we use in the phase 1 clinical trial compared to a control arm, which is a standard of care adjuvant modified FOLFIRINOX. So with that, I would like to just end by thanking all of the people who did the work. All the work that I showed you today was done by members of my lab. Luis Rojas and Zach Sethna did primarily all the experimental work that I showed you here. All of our collaborators. Of course, none of this would be possible without our remarkable team at Sloan Kettering. And of course, I'd like to highlight that all of the work that I showed you today was supported by the Lustgarten Foundation, starting from our initial studies in these long-term survivors. So thank you so much for your help and support with this.
So we're now going to do our panel discussion, and I'll start with the first question, but please, people come up and ask some questions. So Jen, you talked about some targets that were specific between basal and classical. And Jennifer talked about profiling as well and trying to find biomarkers that will differentiate different types. And then Vinod, you went on to say you can actually take a biopsy from a patient and you can make a patient-specific vaccine. So where are we for pancreatic cancer patients? How far are we from being able to just get a biopsy and determine what's the best treatment, whether it's immunotherapy, targeted therapy, or both? What do we need to do to get there?
I would say that we're very close. I think the barriers are we got to get ourselves functional. Like, we have to get ourselves lined up so that our pathways for handling the tissue, making a decision, and a consensus on how to move forward gets streamlined. I think, whole genomes used to take 8 weeks. We can probably do them in a week and a half. You don't necessarily need one. There's all kinds of different ways that we could do it. I think it takes organization and streamlining, and then a platform on which to validate it and study it going forward. And I guess those still have to be clinical trials, so that we convince people that, it's worth maybe waiting a week or two before getting started on standard of care. So I think it's expensive and I think it's complicated, but I think we have the technology now to do it, and I think we should just do it.
Yeah, to add to that, I think the ability to have real-time tissue acquisition testing and clinical decision-making is here. The part that we are working towards that are perhaps on the horizon are the therapies that will inform that. So we can obtain a lot of information now from a small tissue sample, but we still have some ways to go in sort of really being able to act upon the information from those tissue samples in a broad way for patients. But I think all of the efforts that we've been talking about today are all sort of moving towards hopefully expanding the pool of treatments available for patients.
Yeah, I agree. I think we can do it. I really liked your slide about, all the different bins, because I think that's one of the issues is the infrastructure to do all of those tests and figure out if you have HRD mutations. If you don't, then you go to X, and then if you don't, you go to Y, and that there has to be this sort of assembly line of diagnostics. And I think the biggest issues is that the diagnostics are being done at either with different places, right, or different companies. And so that I think is a big problem, even if you can get the tissue acquisition. I will say in our experience with, and I'll speak for Susan Tsai who's now at OSU, she just moved from MCW, but they developed a really nice infrastructure for tissue acquisition that I don't think we really started appreciating until the second site got started enrolling at Honor Health. And that is one of the issues is that you have to have the entire team, which I think you have at Princess Margaret, available to assess all those tissues to really minimize that turnaround time. And so I think the teams have to be available as well from all the different specialties to really process the tissues, evaluate the tissues, do the tests. I think we can do it if we could just get together and do it. I agree.
Take some planning though.
Yeah, I think in your discussion of all the technological expertise we need to do this, it does make me worry that when you start to think about trying to get it out to centers or to places that are remote, it's not going to be an easy approach. So we do have to simplify, but I guess we have to start somewhere. The other question that I find very challenging right now is how do you figure out, see, we have all this data and we know there's this target and that target upregulated, but how do you determine what combination of target therapies you test in a patient? Because we know that one targeted therapy will never be enough. I mean, we've seen this with the PARP inhibitors. We get responses for measured in months, and then we get resistance. We're going to see that with the KRAS inhibitors, I have a feeling, if we haven't seen it already in even the early studies. What's out there? We talked about animal models, but we've talked about organoids. Could any of these help us? Are there computational approaches that are being developed that can help us figure this out? Some thoughts?
I mean, I would say for that, to probably the most bang for your buck would be to do as much science in patients as possible. To have clinical trials where you don't just have drug treatment without any paired science along with it, to really understand if a drug is working, why it is working, and if it stops working, why is it stopping, why is it not working, and if it didn't work at all, then what is the knowledge gap there that we need to fill, and then go back to the animal models to then further decipher and really explore those concepts. So I think as much as we can support really deep translational science in clinical trials, I think it's extremely invaluable for the field and for investigators to be really open to report all their findings as quickly as possible to the community, be that negative data on clinical trials or perhaps a drug works, but it's not based upon the assumed mechanism of action. All of these pieces of information, I think, are really critical for the field to understand what's happening, and so we can build on it and move forward.
I was just going to say, and I think, well, there's numerous possibilities. I think you got to start somewhere. You got to start with your best hypothesis that's based in some other studies and things like that. And then it's complemented with some of the real science that will then be able to address, well, why did it work in this guy and not this other one? And we haven't been able to do that previously. And then I think we need to write these platform studies so that we can be nimble enough to shut an arm and change it up. And again, that sounds in theory wonderful. And if you don't have the buy-in from the drug companies to try that, then it's in real time, it's very appealing to the patients. And you can come back to the companies and saying, well, when your drug doesn't work, we'll be able to show you why, and we'll maybe be able to also tell you why it works so well in someone else. So I think you got to start somewhere, and I worry about combining drugs, but I think we're not nearly as strict about that as we used to be. Like it used to be that you couldn't put two drugs together unless there was a full phase one, and that I think if you know the drugs and the toxicities and they don't overlap, I think we can move forward today and start testing them, in these early trials.
I think, there's a lot of complexities to combinations, and there's so much heterogeneity, I think, in pancreas tumors and the tumor microenvironment that combinations add another layer, because we may think in a preclinical model that either a combination or a single agent may work, but it may have different effects on certain tumor microenvironments or certain tumors. And so all of those factors, and perhaps AI is the answer, but trying to sort of think about all those factors and how it influences your combination is really complicated. And I think one of the biggest pitfalls is that we always do combinations. And so we lose the signal of the scientific understanding of what's actually happening with single agents. And, you know, the one obvious opportunity or window of opportunity trials to really look at how single agents are behaving in tumors. I think it's hard because we know that a lot of single agents will not have a signal, but I think scientifically and in the long run, understanding how single agents actually affect the tumor and tumor microenvironment, understanding the heterogeneity of the tumors is actually going to be really important, but definitely really complicated to do and think about.
Okay.
Yeah, I think the other point will be worth highlighting is I think this is particularly important with biologic therapies because for biologics, as we know, due to potentially differences in pathway biology, the preclinical models may not directly inform the clinical application as opposed to perhaps more so with cytotoxics and targeted therapies. So I think particularly with the biologic therapies, it really is important to try to really understand whether we have target activity and whether the mechanism of action is really what we assume it to be. And if it is not, how might that be different and sort of change our thinking based on that?
You know, I agree with all of you. I think the clinical trial design is clearly going to be important. And like you said, it's all going to be about testing these agents in patients and understanding how they're working in agents. When I think about the immune system, which you and I both work in, I think about how there's compensatory mechanisms that occur every time you hit one signal. It must be the same for targeted therapy too. And I think we need to better understand those. And the nice thing about, or one of the positives that's moving forward right now is a national database that Lustgarten is going to fund around the clinical trials that they're funding. And I think that's going to help us understand how different agents are working in patients. It would be nice if we were able to grow that once it's in existence to include, you know, many of the drugs that are being tried in pancreatic cancer patients, because it's the only way we're going to really be able to understand and then develop the computational approaches that can look at synergistic interactions based on this real data. So I think it's a real complex situation. As far as clinical trials, what do you think? I mean, you mentioned window of opportunity studies for single agents. Are there other clinical trials we should be thinking about and talking to the FDA and to, of course, the Canadian regulators and European regulators about how to move faster on identifying the best combinations? Any thoughts?
I'll just make a push to really challenge us as a field to start looking at whatever markers I think we find scientifically that might predict response, to design trials around those markers so that we stop having these negative trials when we look at all comers. I think that really needs to be incorporated from the get-go, even if, you know, we could randomize biomarkers, but I think we should really think about it as a field instead of looking at markers retrospectively, to be looking at markers prospectively.
Yeah, I do think the FDA has, for these high unmet need cancers, are receptive to out of the box thinking, and not necessarily are aligned with prior pathways of thinking to drug application and safety monitoring and forward path. For instance, in our clinical trial where it was a custom vaccine for every single patient, one question that arose was what would be the best way to assess for safety, since every patient's drug is essentially an N of 1. So how many patients would you actually need to treat to accurately make a conclusion of that the drug is safe? And we worked closely with the FDA in trial design, and they were very receptive to existing information and also the knowledge that pancreatic cancer is a high unmet need cancer. So I think engaging them early and discussing with them, I think they're on our side. Yeah.
There's so much to do, but I think we talked earlier about the locally advanced disease. I think it's a challenging area to treat, and as it mentioned, it gets left off the metastatic trials. But I think we should not forget them and we should focus on them because there is that potential downsizing to surgery in some centers, and that we looked at our own data recently for the two artery involved locally advanced that appeared to respond to some chemotherapy and then got on to surgery. And surprisingly, their outcomes were really rather good. They were almost as good as the earlier disease, which at first made me think that maybe the data was wrong. But I think what it was is that our surgeons actually know when to say no and when to say yes of who they're taking to the OR. So that needs to get studied more so that they know, because that's a huge group that you can really move the needle on with more active agents. You're a surgeon. You agree? Yeah.
In principle, yes. I mean, I think the next major advances I think are going to come with new classes of drugs and new applications of drugs in pancreas cancer. I think across that, and I think scientific efforts as we have seen today are really trying to identify these new vulnerabilities of the cancer and try to hit them in multiple different ways.
So I want to thank the panel. We need to unfortunately move on. We have still more on the agenda, but thank you very much for a wonderful session.
So hello, everyone. I'm Andy Rakeman. I'm the Vice President of Research here at the Lustgarten Foundation. And what an exciting day so far of science and progress that we've heard about. And I think it really points to one of the principles that the Lustgarten Foundation was founded with that's really carried true of if we want to make progress against this disease, we really have to understand our patients. We have to understand the disease. And the way we do that is through steadfast support of research, from basic fundamental research through clinical research that we've heard so much about, and that's what's going to drive us through progress. One of those stories that I suspect we'll hear more about in a little while is work that we supported early on with Dr. Vogelstein at Johns Hopkins, first to try to understand, what are the mutations that happen in pancreas cancer, and to develop tools to have really high sensitivity ways to detect DNA released from tumor cells and circulation that bears those mutations, and then to develop algorithms that allow us to turn detection of those molecules into prediction of who has disease and who doesn't. And that eventually turned into a test that could detect pancreatic cancer as well as other cancers. It was called CancerSeek. It spun out in 2019 into a company called Thrive Earlier Detection, who continued to push on the preclinical and clinical development of that test. And then Thrive was acquired in 2021 by Exact Sciences, who've really been helping to push that forward into something that can be brought into the market and can really make a difference in terms of how we think about detecting not only pancreas cancer, but other cancers as well. And I'm really delighted to be able to introduce Tom Beer, who is VP and Chief Medical Officer for Multi-Cancer Early Detection at Exact Sciences, who's here to help to tell us a little bit about the work that they're doing and what is done. And so glad to have you here, Tom, and glad for the support of this event and of our mission.
Thank you so much for the opportunity to be here. And I might start with a bit of an apology. We're very proud to be supportive of this meeting and of the recognition of Dr. Vogelstein. And as part of that, I was supposed to make remarks and also be here for the award presentation. But it turns out that New York has this thing called traffic, and there are limited flight options to the Pacific Northwest. And I looked up Waze, and it looks like if I'd been one of the top 20,000 finishers in the New York City Marathon last week, I could run to JFK faster than my transportation. But as it stands, I'm going to have to sneak away shortly after making my remarks, and I'll miss the celebration later on. So I apologize about that. I'd like to start by acknowledging the incredible host today, Lustgarten Foundation, for their work in transforming pancreatic cancer into increasingly a manageable disease for many. The foundation has done so much to advance earlier detection, and Exact Sciences is grateful to be a part of this journey alongside Dr. Vogelstein and so many others in the room today. As you know, early detection is a principal research priority for the foundation because we all know that when cancer is detected earlier, patients have a better chance. But right now, 2/3 of cancers still do not have screening options, and pancreatic cancer is among them. Pancreatic cancer is not like some more common cancers where funding for research has historically been abundant. Indeed, when this foundation was first established, pancreatic cancer was generally considered an orphan disease with little interest in the scientific community, relatively little funding, and almost no long-term treatment options for patients. So much progress has been made to date, and now there are scores of researchers around this country and the world working to improve patient outcomes in pancreatic cancer and to discover the sort of breakthroughs that you've heard about earlier today. And the Lustgarten Foundation, of course, is at the center of this community. And I'm so grateful to be here with the foundation and for the foundation bringing us all together to recognize and celebrate the visionary that is Bert Vogelstein. With vision, passion, and relentless determination, he not only revolutionized our understanding of this complex disease, but also transformed the landscape of cancer early detection. Dr. Vogelstein's groundbreaking research has led to the development of less invasive, yet highly accurate methods for detecting cancer through the analysis of circulating tumor DNA and other circulating biomarkers in the bloodstream, offering, I think, a ray of hope for all of us. At Exact Sciences, Dr. Vogelstein is a bit of a celebrity because his pioneering work in unraveling the mysteries of how cancer starts, develops, and grows into the aggressive disease that it can be is a foundation that drives our discovery work and our test development work. Dr. Vogelstein is not only committed to unlocking the secrets of cancer development, but he's also determined to do something about it. And this commitment drove Dr. Vogelstein to make fundamental discoveries in multi-cancer early detection. You've heard a bit about that earlier today. And in fact, it was this foundation that got the CancerSeek test off the ground through substantial research investment in the Vogelstein lab at Johns Hopkins. CancerSeek now serves as the prototype, the foundation for the assay we're developing today. And, you know, multi-cancer early detection is a really compelling opportunity for pancreatic cancer and many other cancers. You heard earlier today that the average risk of pancreatic cancer in the general population is about 4 per 10,000. And that's why it's so difficult to conceive of screening tests for average risk individuals that target pancreatic cancer specifically. Now, one solution for that is to better understand who's at elevated risk and high risk, and to target those groups for early detection using a pancreatic cancer-directed test. And that is a very important avenue that's likely to yield important progress. Another approach is to tackle the problem through multi-cancer early detection, where single tests are designed to detect multiple cancer types and aggregate the prevalence of cancer so that we can take advantage of that larger risk across a broad range of cancers to develop tests that detect pancreatic cancer as well as other diseases. After all, our risk of any kind of cancer is closer to 1 to 2% per year, and that's a number at which we can begin to conceive of developing early detection tests. Exact Sciences brought the first cancer screening test based on the understanding of cancer biology to patients in 2014. As of this year, more than 13 million people have been screened for colorectal cancer using Cologuard. Based on known prevalence data, We estimate that this testing effort has helped to find precancerous lesions and early stage colorectal cancers in nearly 500,000 individuals. That's powerful. And our new in development MCED test, which we call Cancer Guard, is being developed to build on that impact and extend cancer screening to many other cancers, of course, including pancreatic cancer. Now, going back to the foundational work that came out of Johns Hopkins, in 2020, the first ever prospective study of a multi-cancer early detection test was published. This is the study that examined the CancerSeek test in about 10,000 women, was led by Dr. Lennon, whom you've heard from earlier today, together with her colleagues at Johns Hopkins and Geisinger. In that study, a single application of a prototype multi-cancer early detection test picked up more cancers than all standard of care screening tests combined in that group of patients. And now in 2023, with longer follow-up, we're able to confirm that amongst those women, every single patient who had a stage 1 or stage 2 cancer diagnosed through MCED testing and was treated remains cancer-free and alive more than 4 years later. That's what Dr. Vogelstein's work makes possible. Dr. Vogelstein's passion for his work is not only evident in his discoveries, but also in the countless lives that he has touched through his dedication to educating the next generation of physicians and scientists. His mentorship has inspired many, ensuring that his legacy will continue to influence the field of early detection for generations to come. And in fact, there's a personal connection there for me. Dr. Vogelstein was a big influence in my own passion for discovery in medicine when I started my medical journey at Johns Hopkins in 1986. I met Dr. Vogelstein then. I suspect he didn't really meet me because I was one of 120 medical students. But what I learned from him really drove how I approached my career. I got a chance then to reconnect with Dr. Vogelstein recently when I took on the role of Chief Medical Officer for multi-cancer early detection at Exact Sciences, where my job is really to steward the discoveries from the Vogelstein lab and others and work hard to turn them into a useful test for patients. So it is a great honor indeed to offer these remarks and to be present here on this day of recognition for Dr. Vogelstein. Thank you again to the Lustgarten Foundation for your tireless work and your meaningful partnership in the fight against pancreatic cancer. Thank you very much.
So we're going to segue right into Bert's presentation. I'm going to give my version of an introduction to Bert. Tom's was terrific. So our honoree tonight is Dr. Bert Vogelstein, who's a distinguished cancer geneticist and biologist and medical doctor from Johns Hopkins. We consider him a pancreas cancer expert, in addition to his expertise in the rest of the cancer field. He's worked with us at the Lustgarten for the past 15 years. So Bert started out working on colon cancer and really identified most of the important and relevant genes in this disease. The concept of stepwise acquisition of mutations really came from his work with Eric Furon and many of his terrific trainees in his laboratory. He turned his attention, though, to pancreas cancer in part when he did his first project with us. And this was the first time that the pancreas cancer somatic genome was correctly described. And this was followed with a very, seminal paper in 2008. Following this publication, he was invited to and accepted our invitation to join our SAB. And he's really given us fabulous advice over the past 15 years. And I personally have benefited for the past 12 years from that advice. In his own laboratory at Hopkins, he's trained dozens of scientists. So if you ever visit his lab, how you see the tree of life and, all your trainees and things like that. He needs like a whole wall because he's trained that many people who've gone on to not just make Hopkins, a fabulous place, but a lot of the other institutes that have been represented here today. And, he has many notable discoveries. Tom certainly mentioned some of them, but it includes the identification of checkpoint immune therapy for microsatellite unstable colon cancer with Dr. Louis Diaz and Dr. Dung Lee and Dr. Elizabeth Jaffe. Another notable accomplishment, Tom covered very nicely this first pan-cancer blood test, and we're watching, hopefully, to see how useful that will be for pancreas cancer. We've asked him multiple times over the last 12 years to think outside the box, think beyond his own laboratory. What would he do to make pancreas cancer go away? And one of his ideas he came to us with was we now call an artificial intelligence machine learning approach, but it was mostly described as they had recruited to Hopkins a physicist who was important in designing the driverless car. And he was going to work with Elliot Fishman, who runs who's the expert radiologist in pancreas cancer at Hopkins. And so they proposed a project, and the project is called Project Felix, for those of you who've heard of it, and which has implications in the Harry Potter movies, where you put the blanket over your head and you can't see the person under the blanket, with the notion being that if they were smarter, they could see that tumor before the radiologist could see the tumor, before a report light bulb went off. And the project has really been fascinating to watch develop. And while it's still early days, the data is pretty provocative. There have been multiple papers. There are investigators who work for Microsoft who are now involved. And it's really galvanized the community for taking that type of approach for breast cancer and for other cancers, et cetera. And so really, from his many accomplishments as a tireless scientist, he's very famous for being the first person to the lab and the last person to leave. His most important thing is how close is his parking spot to his lab, not how big is his parking spot. It's like, things like that. So he's a tireless scientist, mentor to so many, visionary for cancer research in general, pancreas cancer in particular. We're really grateful for all Bert's done for our field. And he makes the best and most fitting recipient of our inaugural award from our own foundation, our Visionary Award. So let's give it up for Dr. Vogelstein. Right. At the end of it, I do have to leave before you're done. Yeah, I go to.
Yeah. That was, I really appreciate those introductions, both by Tom and by Dave. Makes me feel that all the people that have worked with us, some of whom are in the room, makes me feel good, very good about that. And I think makes them feel good too, which is even more important to me. So my task today is to get this on. Aha. Yeah. All right. The title is Challenges and Opportunities for PDAC. Whoops. All right. Look at that. Yeah, you'd think if I were as good as Tom and Dave said I was, I should be able to figure this out on my own. But Help is always welcome. So I'm going to divide this lecture, I guess, up into 3 parts. Help, get rid of that. I got it, I think. Yep, we're good. All right. First part, understanding the origin of pancreatic cancer. Secondly, developing better therapeutics. And third, detecting cancer earlier. There are challenges associated with each of them. And I will espouse those challenges as we go along and hopefully stimulate the audience to think about them a bit more. So let's first start with the origin of PDAC. This is a slide that Laura Wood made in one of her papers a few years ago. Laura Wood was actually a lead author on that pancreatic cancer study that was mentioned by Dave, I think, from 2008. Now, she's, of course, a faculty member, but it's generally thought that KRAS is the gatekeeper of pancreatic cancer, and that's indicated on this slide. Laura and I have been discussing this for a couple of months, and we think that may not be true. So let me tell you why. This line of reasoning started actually quite a long time ago through the analysis of cysts. As you know from session 1, cysts cause some fraction of pancreatic cancers. The rest are started by pannins. And this study and several like it were led by Anne-Marie, who you've heard from before today. And this came from whole genome sequencing of a variety of cyst types, 4 different cyst types, SCA, you can see them on the left. And this audience, I'm sure, is aware of them. What I want to point out about this slide is that each of these cyst types has a completely different pathogenetic basis. Their mutations are not shared. So my hat is off to the pathologists and the radiologists who are able to discriminate these lesions simply by histology and radiology long before any genes which are responsible for them were discovered. And the most notable thing in these studies, to me at least, was that IPMNs and MCNs, both important precursors of pancreatic cancer, had multiple gatekeepers. All of these 3 genes, KRAS, GNAS, and RNF43, are thought to be gatekeepers. By gatekeepers, I mean those mutations which are believed to initiate the cancer. If they don't have that gatekeeper mutated, they can't progress. Now, this does not make sense. There can only be one gatekeeper in one cancer or in one precursor. And this, even though it was a while ago, started us thinking that something's not right. And it reminded us, even back then, of the situation in colon cancers and other cancer types we had studied before we became convinced that pancreatic cancers were the most important cancer type to study. But at any rate, there, we and other labs had noticed that you often have multiple KRAS mutations in an adenoma, a precursor to cancer. But then in the cancer itself, only one of those clones, only one KRAS mutant clone actually expanded to become the cancer. And that made sense because APC was the gatekeeper. It started all colorectal neoplasms. Then as the colorectal neoplasm progressed through its adenomatous stages, multiple different parts of it acquired different KRAS gene mutations. And through a process of clonal selection, one won out, one mutant won out, and then became the cancer. And Laura, in association with, is Keeman a graduate student, Laura? Is she here? Or a postdoc? Yeah. Has worked out a beautiful way to do three-dimensional imaging, which is shown here, which has allowed her to figure out how many pannins there are in a typical pancreas in a 65-year-old man or woman. As you can see from this slide, which is published in bioRxiv by Laura, that there are about 1,000. That means every person who's, roughly 60, 70 is going to have about 1,000 of these. And from the incidence of pancreatic cancer, if you do a calculation, that means roughly one of those 100,000 low-grade pannins, and I'm emphasizing low-grade, will progress into a cancer. That is a very low risk. Now, what does 100,000, 1 in 100,000 risk mean? I looked that up in Google last night, and I found that skydiving is associated with a 1 in 100,000 risk of death. Now, that is a lot lower than I thought it was. So I may go skydiving. However, I also found that dance parties carry a 1 in 100,000 risk of death. And if you learn one thing from this lecture, probably is not to go to dance parties. But getting back to the topic of interest, and let's go back to the colon. There are two types of early precursor lesions in colon, and they are microscopic, just like pannins. They're called aberrant cryptfoci, they're not called pannins. And on the left are hyperplastic, and on the right is dysplastic. The hyperplastic ones obviously have a different histology. They have a very low, if any, risk of progressing into colon cancers. And their gatekeeper is KRAS. On the other hand, the dysplastic aberrant cryptfoci, they have a much higher risk of progressing, and their gatekeeper is APC. And this is not a progression kind of thing. They're two separate kinds of lesions, just like the cyst I showed you before. An IPMN is not a precursor of SCA or vice versa. And Laura and I have been discussing the possibility that it's the same thing with pancreatic cancers, that the two different kinds of precursors are, one, low-grade dysplastic ones, and two, high-grade dysplastic ones. And Laura was just showing me some slides last week. Those low-grade dysplastic lesions look a lot to me and to her, I think, like hyperplastic colon lesions. And in one, in the low-grade dysplasia, the gatekeeper is KRAS. But we don't know what it is in the high-grade dysplasia. Now, and we don't think, or at least one of us doesn't think, I'll put it that way, that they go from one to the other. So this is a challenge opportunity that I would like to present to this audience. What is the gatekeeper for pancreatic cancer? If they really do start, if the real precursor lesions are grade 2 pannins, then what is the genetic or epigenetic alteration that starts them? We know it's none of the known genes. There have been too many sequenced. We can rule that out. So it's either some dark matter of the genome, some promoter mutation, some duplication, or an epigenetic change. But I think that's critical because KRAS is the only oncogene involved in pancreatic cancers. The rest are tumor suppressor genes. Now, unfortunately, the only cancer driver gene products that can be targeted are oncogenes. That's true in all cancers, and it's true in all of medicine. You can only target proteins which are present. With tumor suppressor genes, the product, the protein, is often absent. You can't recreate a protein in a cell. So if the postulated gatekeeper of pancreatic neoplasia is some oncogene, it could give us a second target to drug, which then maybe in combination with the new RAS inhibitors would be sufficient to actually get cures rather than short-term remissions, as you heard we're likely to get from the last session. But this also brings up another challenge, the second challenge and opportunity. How can tumor suppressor genes be targeted? There are two ways that I can think of. One, of course, is not to target them directly, but indirectly. And in order to do that, you have to understand the downstream pathways. When a tumor suppressor gene product goes down, the protein goes down, some other protein must be elevated. And with better understanding of the pathways, that is a viable approach. I encourage everyone who's working on pathways, the basic scientists who are doing that, to do more and more and learn about those that are in pancreas cancers, which are not necessarily the same as in other human cells or other organisms. The second way is immunotherapy. Now, you're all aware here, there are two basic kinds of immunotherapy. You've heard about vaccines from Liz and immune checkpoint inhibitors from others. The ones our lab has been pursuing are, you can call them directly targeting their products, either with bispecific antibodies or CAR T cells. And our target is MANUS, mutation-associated neoantigens, something we labeled, I don't know, about 15 years ago in those first studies of comprehensive studies of the genetic alterations in cancers. And the antigen here is not so much a protein as a fragment of a protein, a peptide buried within the groove of an HLA molecule. And this is difficult. It's difficult because they're intracellular, so you'll have to target these PHLA complexes to make them visible to the immune system. It's difficult because the antibody or whatever recognition unit you use has to distinguish only one amino acid, the mutant amino acid, from the wild type amino acid, and they're expressed at very low levels. Now, fortunately, we have a group of investigators in our lab. We call them the X-women because they do extraordinary things, a few of which I'll show you today. And one of them in particular has developed a very potent antibody to one particular MANA. It's a P53 MANA. P53 is the most commonly mutated tumor suppressor gene in pancreatic cancer. And the most common mutation in P53 is R175H. And this is a PHLA complex. The most common HLA type in Western populations is HLA-2. So that plus other factors are why she and other members of the X team chose it. And here's a picture. Again, most of the work I'm showing you today has not yet been published because I thought that would be more fun and exciting to discuss. But the T cell therapeutics that one could use to target these, we've already described in published work bispecific antibodies against that manna. But there are two kinds of T cell therapeutics. One uses the recognition domain of antibodies. They're called CAR T cells. The other one uses T cell receptors. And they're different. And the main difference for our purposes is that recognition by TCRs, these are naturally occurring TCRs, only requires 1 or 2 antigens on the cell surface. It's really almost miraculous how sensitive they are to antigen density. Whereas CAR T cells, at least those that have been used in the clinic so far or described in the literature for the most part, require thousands of antigens. CD19, for example, is the prototype for treating B-cell leukemias and lymphomas. So, unfortunately, on pancreatic cancer cells, these PHLA molecules, such as the R175H mutant of P53, are only going to be present in a handful of molecules on the cell surface. So how can they be targeted? And can we combine the advantages of CAR T cells, which are multiple in terms of producing a useful therapeutic agent, as well as for manufacturing, as well as for manipulating the antibody? How can we make them as good as CAR T cells that recognize the same antigen? And that challenge was given to a member of the X-Women, who's Brian. They're obviously not all women. And Brian is here with us and has presented a poster, which I encourage any of you who are interested in learning the details of this to see after this presentation. But at any rate, that was Brian's task. Make a CAR T cell as good as a T cell with respect to its ability to recognize cancer cells with low antigen densities. And he started with standard CAR T cells, so-called 2nd or 3rd generation T cells, compared them to TCRs. In this case, Rosenberg's lab at the NIH had made several different TCRs to the same antigen, the P53R175H antigen. And in each case, Brian knocked them in to normal T cells, making sure they had even levels of expression, which would allow an apple-to-apple comparison. And here is the result. This is an interferon. This is 2 cell lines. One is a cancer cell line with R175H mutation. That's in blue. The red is the same cell line in which Brian knocked out the R175H mutation using CRISPR. The green is just a control with T cells only. And on the y-axis is interferon gamma, which is a measure of recognition by the T cells. And you can see and here's Brian's CAR1 and CAR2 on the left, and the TCR in the middle. And you can see the TCR worked great, lots of interferon, and Brian's didn't work at all. I mean, failure, okay? So maybe it was different with cytotoxicity. Nope, same thing. TCR wins. Now, this was expected because we knew that CAR T cells, even the best CAR T cells, would not recognize cancer cells bearing low antigen densities. But of course, he didn't give up. He learned from nature and tried to modify the TCR so that it would incorporate the antibody. And he was helped immeasurably Well, a lot of the truly great scientists who have worked out CAR T cells in the past and have inspired Brian and the other members of our lab, some of whose names are listed here. And this is the first combination TCR CAR1 that Brian made. You can see the antibody is appended to the constant change of the TCR. This didn't work either, but after a couple of hundred constructs and many years of working, he developed one which he calls a co-star. And again, that's what the poster outside is about. And briefly, it works, and it works considerably better than TCRs. You can see the untreated mice on the left, the TCR treated mice in the middle, and the co-star treated mice on the right. It cures mice, and this is with it cures mice with significant disease burdens. And this is unusual in our lab's experience to have them really cured. I mean, as long as the mice live. We know why they work. Brian was able to figure out they work because these T cells persist. This is why our lab is focusing on CAR T cells and their derivatives, now co-star cells, because we think that in order to fight fire, which is the cancer, we need fire. And CAR T cells or other kinds of cellular therapeutic agents are the only ones that can multiply and keep pace with the tumor once they're injected. So in some of these mice, we see what looks like relapses in a couple of months. The relapse lasts a week or two, and then they're killed by the remaining co-star cells. Now, will this work in the clinic? I, of course, have no idea. I have high hopes, but no idea. But this presents the third challenge opportunity, and this one I address to the clinicians and clinical trialists in the audience, because I think there are real opportunities here, a couple of which I'll mention briefly. The first is based on old observations that whatever you're using to treat, including CAR T cells, like in this slide, if you have a low tumor burden, you have a chance of success. If you have a high tumor burden, you have no chance of success. And this is true, again, for any therapy, whether it's CAR T cells, immune checkpoint inhibitors, conventional drugs, targeted agents, doesn't matter. Every study that has ever examined this shows this. And of course, it makes total sense. The more cancer cells you have, the more likely there will be a resistant variant. Now, with that knowledge in mind, I think future clinical trials would optimally use stage 1 and stage 2 patients, which have lower amounts of disease. This is what's gonna make new drugs work when they won't work in end-stage patients. This is good for pharmaceutical companies. In my view, every pharmaceutical company in the world should give $1 billion to the Lustgarten, because and I'm quite serious about that, because it's going to make their drugs work better. Now, the problem with treating stage 1 and stage 2 patients in the past is you never knew whether they were going to relapse or not, and it could be 2 years, 3 years, 5 years. Not so much for pancreatic cancer, but certainly for other cancers. But that's just no longer true. We know who has disease, even if you can't see it radiographically now. And I'll just very briefly present some other unpublished work, this time by a young scientist at Hopkins named Yuxuan Wang. She's developed a technique to detect minimal residual disease. It's based on a personalized assay, whole genome sequencing of the patient's tumor. She picks out 96 mutations, very carefully chosen, very low background after studying thousands of normal individuals. She assesses both Watson and Crick strands to ensure specificity. And the bottom line is she can detect one cancer cell releasing DNA into the whole body circulation. So she samples 10 mils, but because of the nature and the power and the number of mutations she's studying, that translates to being able to detect one mutation per body, one cancer cell that releases DNA into the whole 5 liters of circulation. And this allows one to tell who is a stage 1 or stage 2 or a patient that doesn't have residual evidence of disease, but still has molecular evidence, just like what's commonly done in leukemias. And here is just a few examples of her studies in 3 different pancreatic cancer patients. So this is one patient with a PDAC. On the x-axis is time since surgery. On the y-axis is the number of cancer cells releasing DNA per hour. And you can see that there's no detectable DNA released into the circulation. This patient had adjuvant therapy, as noted in the blue square, and no relapse 32 months after surgery. This is the result you want, of course. You could say, well, did this patient really need to be treated with adjuvant chemotherapy? At the time, I don't think one could withhold, but in the future, that's a possibility if cancers are detected early enough that you could withhold adjuvant. Here's another patient. This time, you can see from that peak right at the 2-month time point that the patient was positive, but the therapy actually worked. This is the chemotherapy, and it brought it down to 0, undetectable. And this patient was not cured, but didn't relapse clinically until 20 months after surgery. I imagine if Yuxuan had studied that patient longer, she could have seen the relapse, the molecular relapse, long before the clinical relapse, and more therapy could have started. But this is still, I think, an important result. Their arrow marks a relapse. And here's the third example. Here, the therapy didn't work. It takes Yuxuan with her assay a week or 2 to figure out whether the therapy is working. You don't have to wait for a radiologic response. You don't have to wait to the patient to feel better or worse. All you need to do is measure the number of DNA molecules in the blood with an assay that's worked out by the time that the patient has started. And this patient, you can see the DNA just went up like a rocket, relapsed just a few months afterwards. And the importance of this for managing patients is, obviously, this patient didn't need 6 months of adjuvant therapy. You could have told within a week, this is not going to work. Let's put the patient on a different kind of therapy, an adjuvant therapy, a trial sponsored by the Lustgarten, rather than the traditional adjuvant therapy. And the future is now for this one. I mean, this can be done. I was encouraged to see that some of the people in session 2 mentioned this possibility, but there are lots of companies selling these assays, perhaps not quite as good as the one Yuxuan worked out, but good enough to help manage patients, and I think help both the patients and the physicians manage their disease. So I hope this kind of thing can be instituted very promptly. Now, I'll finish with one last session. How much time do I have left? 9 minutes or so. Okay, why can we cure mice? We in our lab are really good at curing mice. I personally have cured many mice, especially ones I have injected cancer cells into about 2 weeks before. And here's why. Here's a typical patient with a metastatic pancreatic cancer in a phase 3 clinical trial. And here is a very large mouse tumor, which I put next to it. And remember, this is 2 dimensions. In 3 dimensions, it's an exponential difference. Here's a whole mouse. So each one of the tumors in a human patient are as large as a whole mouse. Again, it's just a numbers game. If you can cure 1,000 mice with large mouse tumors, you'll have a good chance to cure 1 human person. But you hardly ever see that in experimental studies in mice. The drugs just aren't powerful enough. You need something else. But that's why it's easier to cure mice. So how do we rectify this? Well, we could make people turn into mice. I would hesitate to put a grant in on that. But earlier detection can make human tumors more like those of mice because they're smaller. And it's just a numbers game. The smaller the tumor, the more likely there will not be even a single resistant cell to whatever therapy you're doing. And we have a window of opportunity. There's 10 years in the making between a Panin-2, a high-grade Panin, and the initiation of a cancer, and another roughly 10 years, lots of variation between the initiation of the founder cell of that cancer and metastasis. And this is based on some mathematical modeling from the NOAC group. It was published a while ago and it still stands. So this is our window of opportunity, several years to detect the cancer, hopefully at stage 1, but certainly before stage 3. Can we do it? Well, probably the best systemic way to do it at present is liquid biopsies. And you can divide liquid biopsies, at least those focusing on DNA, to 2 kinds. Genetic, looking at mutations in aneuploidy, and that's what our lab has focused on. And you heard Tom talk a little bit about Exact trying to develop tests based on that. And there are other kinds, epigenetic, either DNA methylation or based on cell-free DNA fragment size, DNA fragment and motifs, fragment genomic locations. And Sam Curtis, a graduate student in our lab, has been working on these epigenetic assays using some pretty sophisticated machine learning algorithms developed actually by my son, Joshua, who is a computer scientist at Hopkins. But at any rate, when he combines mutations and all these other techniques, this is what we currently estimate our sensitivity in the real world might be, if we're lucky, but I think it's a conservative estimate, for stage 1 PDAC, 30%. And that's combining mutations, aneuploidy, epigenetic, everything we can think of at very high specificity. Now, 30%, what does that mean? Well, it depends on how you look at it. You know, a lot of people might say, well, 30%, that means you're not getting most of them. 70%, you've done nothing for. The other way to look at it is suppose you had a drug that would actually cure 30% of pancreatic cancer patients who would otherwise not be cured. You'd probably be jumping up and down. So it all depends on your view. You know, the cup is half full, half empty. But still, to me, I think this is a reasonable start. It's not a finish, but it's a start. And if this really could be done in the real world and get 30% of patients to actually present or be detected at phase 1, I think that would make a major impact on PDAC deaths. Now, what is the future of this assay and PDAC cancer research in general? Because they're tied together. How do we get that 30% up to 90%? What does the future hold? So this brings us to the last challenge opportunity I will enunciate, which is predicting the future. And that's the hardest. So who can predict the future? Scientists, usually not. We're too tied to reality. We see the limits of our technology. We see the day-to-day, how experiments don't work. On the other hand, science fiction writers don't have that obstacle in their way. They can use their imagination. So here's one of my favorite scenes. It's from Elysium, starring Matt Damon. I don't know if any of you have ever seen this, but briefly, here's what it is. This machine, it's in everybody's home, at least everybody who's rich, who lives on this world, and it's not working despite my practicing this 200 times. Okay. So anyway, this thing comes over him and it diagnoses him. This kid is having leukemia. Now, it takes 2 seconds, right? It's total science fiction. Couldn't possibly happen. Well, look at this machine. This machine did happen. And if you had asked me 50 years ago whether this could happen, I would say, are you nuts? And this is just an MRI. Right? Not that much difference, at least conceptually. It just requires new developments. So, in ending, what's the future of pancreatic cancer research? And this is my last slide. I think it's 2 things. It's first, young scientists thinking a little more like science fiction writers and a little bit less like scientists. And second, having foundation like the Lustgarten with the guts to fund that kind of research. And I'd like to, of course, thank the other members of my lab who I didn't mention, disclosures, and again, thanks to Lustgarten and to you for your attention. Greatly appreciate it.
So, Bert, I get to close
Cool.
with you up here.
Oh.
It's all about you.
Oh.
So I did write a few points down, but what an incredible lecture. And I think Bert always takes us to higher levels, things we've never thought about. And this is why you're so deserving of this award as the inaugural Lustgarten Award. I mean, you've taken science, you've taken all of us young people. I'm no longer young, but when I was young, he was one of my mentors. He still is. I looked up to you for so many years, as has everyone. And you took on pancreatic cancer at a time when no one else was willing to do it. And we all followed. And it's just been an amazing journey, just seeing how you've mentored generations of young people. And you pointed out constantly, and we're all still following you. So I just wanted to end. I know Bert's the important person here, but I don't know if you realize, but at Hopkins, we all call Bert the rock star of cancer research. Do you realize that? So we call him the rock star for 2 reasons. One, we can't think of anyone else who we could idolize as much as Bert. And this is everyone at Hopkins, young, old, it doesn't matter. Bert is our rock star. And then the second reason is, I don't know if you guys realize this, but he really does have a rock band. So, so Bert, thank you so much.
Very nice. Thank you.
With our honor to award you with our inaugural Luminary Award. Everybody, Bert Vogelstein. Well, that was definitely the best part of the afternoon, the applause for Bert. So thank you, Dr. Vogelstein. Just a few more things, and I promise, because I know that we took away your afternoon break, but we do have a reception outside for you after just a few more things. The reception this afternoon is sponsored by Merus, and please join me in welcoming Dr. Bert Mulvey, the Director of Field Medical Affairs at Merus, a clinical stage oncology company developing innovative full-length multispecific antibodies as targeted treatments to address the unmet needs of patients with various types of cancer. And it takes a village, and we're glad that Merus is part of ours. So please welcome.
So, hello everyone. It's really an honor to be here at Seeing Beyond. And first off, congrats to the Lustgarten Foundation for 25 years of clear impact in pancreatic cancer. I think that was evident from what we saw. So as Linda mentioned, I'm Bert Mulvey. I'm the head of the Field Medical Affairs team at Merus. My background is in molecular biology and translational research. So I was really excited by the program, and this has been a fantastic day of talks and just experiencing what the advancements have been in pancreatic cancer. And Dr. Vogelstein, I did get to speak to your, I go to the poster and speak to Brian about the project on, you know, looking at from one of your ex-woman. So it was great to speak to him and you know, learn more about the advances that are going on. It was super encouraging. And one of the things that I shared with him that was impactful from my postdoc and during my time was a patient quote. And it just meant so much to me because a patient said that one of the things that gave them hope always at all times was that they always saw the lights on in the labs. And it touched my heart. It just meant a lot to me because I knew how much work that I put in the lab, how much effort and dedication that goes into the research behind all of this. So it was just really special to me to have that and to be thinking about that when I'm working those late nights in the lab and putting in all that effort. So I think, especially with the Lustgarten Foundation, because I think they're part of what keeps the lights on. And I know how important funding is to this research, and it's so important to get funding to the right labs and the right people and to create that innovation. So with that being said, I'm really thrilled to be part of an organization that is funding innovative science. And I just want to take a very brief moment because I know we're running up on time. So just want to introduce Merus before welcoming you to the reception. So Merus is an oncology-focused company with 4 clinical assets of our own and multiple others in the clinic that we've developed with our collaborators and through licenses. So we have a proprietary multi-clonics technology platform that allows us to make multi-specific antibodies like monoclonal antibodies. In particular, our most advanced molecule, zenocutuzumab, has shown really impressive data in the area of NRG1 positive PDAC. So Zeno was recently granted breakthrough therapy in PDAC, and as well as non-small cell lung cancer. So we're really excited about Xeno and the opportunity to help patients in PDAC. And I really appreciate being included in this extraordinary group. And I wanted to personally welcome you to the reception. So thank you so much.
Please join me in welcoming Lustgarten's chairman of the board and Mark Lustgarten's son, Andy Lustgarten.
Such a formal intro. Thank you, Linda. First off, I just want to say thank you to everyone for coming. Thank you, Linda. Thank you, Dave, even though he had to slip out. Liz, thank you. Also, I really appreciated the words you said about my father. I had never heard some of those things you said before, so it's pretty amazing. But which actually ties a little bit to what I want to say here, because it's when you think about where we are today and where this started, the first year of the foundation, we couldn't even figure out really what to fund because there was almost no science, right? It was so few people pay attention, so few, it just was the cancer that no one wanted to talk about because we couldn't, because of how difficult it is. Now we're 25 years later. I really was hoping we wouldn't be here 25 years later and then we could have solved it already. I mean, what we see today and what else I've seen from everybody, you know, being around it, I feel like there's a big move in what their science is. And compared to where we were, where we couldn't find pieces of science to fund, we're now at a place where there's lots of great science to fund. And it's a place where we're no longer just people's in an idea, we're actually talking about clinical studies. So it's just a change in where this terrible cancer is. What I will say is, I really don't want to see you here in 25 years and hope we're out of business before then. So let me just make sure I didn't miss any key stuff. But look, I think we are changing this disease, and you really are the people who are changing the disease. So thank you, because we couldn't be where we are today without you. And again, I don't want to see you here in 25 years. And the foundation's given $280 million to science. And so it's pretty. But thank you, Bert, like for things that you and other of the great scientists have come up with, we're able to give that money. And I hope to God this will be done soon. So thank you.